नमस्ते अर्चना मिश्रा मैम।
So Vishal, we are past 4, so we can start the countdown.
Ronak has started countdown.
Okay.
Yeah.
Ronak, are we live now?
No, sir. Just allow me 10 seconds more, please.
Yes.
Okay. No problem.
We are live in 3, 2, 1. We are live now.
Good afternoon, everyone. Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. I welcome you all for today's Perfection Series Season 7 in collaboration with Central ISAR. Today's topic is multifetal gestation, latest perspectives. My honor to introduce co-convener of this Perfection Series, Dr. Monica Jindal Singh. She is consultant reproductive medicine at Bhopal Fertility and Endoscopy Center, Bhopal. She is Vice President, Bhopal Obstetrics and Gynec Society. She is Vice President, Bhopal Menopause Society. She was Organizing Secretary of 27th Annual ISAR Conference 2023 held at Bhopal. She is also Central Zone Coordinator of Foxing Middle Committee.
Thank you.
Over to you, madam.
Thank you. Thank you very much for the kind introduction, Dr. Vishal. And at the outset, I congratulate our very honorable guest. She's not a guest, she's the convener of Perfection Series. She's the reason because of which we could start this series. And this is a special Perfection Series for us because it is first after her winning the election for Foxy President 2025, when she will take charge. So we congratulate Dr. Sunita Tendulwalkar. And it was because of her vision and Dr. Nandita Palshetkar, President ISAR's vision, that we started the first episode of Perfection Series way back in March, immediately after the 27th annual ISAR. So can I introduce the dignitaries now, Dr. Vishal? Next slide. We can't hear you, Vishal. Your internet is, I think, disturbed. Yeah.
Okay.
Yes. So we know that Dr. Nandita Palshetkar is President ISAR, and she is the vision, the head behind so many organizations she has been in India. She is a dynamic lady who has headed multiple gynecological associations of India with aplomb and brought them forward to the international. At present, Madam is in Greece, so she'll not be able to join us. She has sent her best wishes. Welcome, Madam. Next, I would like to introduce Dr. Sujata Kar, the Secretary General ISAR, and she's also a great leader, and she's always there to help us out. She will take your calls at every minute, every hour of the day. She'll call back when she misses a call. And she is a great academician. I remember my first interaction with her during ESHRE, where she was reading a paper. Madam is in Australia right now, so we will be holding the session without her. But of course, we have her blessings. Next, it is my great honor to introduce our Vice President ISAR, Dr. Sunita Tendulwalkar, without whose vision we would not have started this program. So this series of Perfection Series was something like a focused discussion group. But instead of having several groups, we tried to introduce one topic into perfection every time. That topic could be taken from either gynecology or obstetrics or ART or ultrasound fetal medicine, where we could get all the stalwarts together and speak about it. Madam is head of department, Ruby Hall Clinic, Pune. She has now started becoming a very good robotic surgeon as well, because we've seen her videos. She is-
Monica, no,
Yes.
enough, beta.
Madam, I
Let's be
want to-
academic.
Okay, ma'am. But ma'am, I
Like-
just want to tell everybody about your stem cell project. And now you had promised us that after winning the election, you will go and start taking out the stem cells from fat cells.
Yes,
so
yes.
that-
We are we are leaving. End of
Yes.
September, I'm not here only because we are going for a adipose tissue stem cell treatment, this thing.
So ma'am, we are so excited about that project of yours, and I'm really sure we'll have a stem cell baby from the fat cell of the mother now. So that's so
Let's see. Let's see.
Thank you so
Actually,
much, ma'am.
Thank you, dear. And let me congratulate you and Randhir, the brainchild behind this Perfection series, and the passion with which you are taking out the subject which you choose are absolutely amazing. And I'm sure today's multiple pregnancy, which is really a burning topic, all the ART consultant, can we stop my slide? All the ART consultant together, we used to study in our residency 40 years ago, the Niles rule of 3 and 2 and everything. It all get scrapped out because of we all ART consultants, where the multiple pregnancy probably has gone to 20-25%. So it's important for us to learn it from a clinician's aspect, from the fetal medicine person telling us, and different case scenarios. So I'm very sure today it will be of a great use. And it's not only the ART consultant who are managing it. Many ART consultants don't do obstetric practice and they hand over to their colleague to manage these patients. And naturally, even the IUI, ovulation induction, is so perfectly performed by all the gynecologists doing IUI practice. Unfortunately, that is also giving us multiple pregnancies. So it's a high time. One, maybe next time you can think about, Monica, single embryo transfer, maybe by selection by morphological criteria, or maybe by taking a AI into the practice, where we will decrease the multiple pregnancy results, you know, by artificial intelligence helping us to select the best embryo, which has a probability of getting implanted. And today, we all clinicians just don't want to believe our embryologist who tells us the grades according to the morphological criteria. And because of that, we tend to put 2 blastocysts and we land up into multiple pregnancy. But if the AI comes in, we probably will be able to do a single blastocyst transfer. Maybe 5 years down the line, everyone will start doing it. And 10 years down the line, we will not have the multiple pregnancy topic only to be discussed unless it is a IUI giving multiple pregnancies. So every center today, they feel the success rate is how your implantation or a clinical pregnancy or live birth rate. I think 5 years down the line, our success rate will also be spoken, or the quality of your ART center will be looked upon by your multiple pregnancy rate. Lower the rate, better the center. You understand? So this is how probably I see when it comes to multiple pregnancy and thinking or discussion. This is what I'm very sure today's topic, when you have such excellent speakers and the moderator yourself with the excellent panelists, we are well experienced in everything. It will be of a great help. I'm thankful to each and every one of you for supporting me in my journey of Foxy Presidency. And all my great supporters here, thank you for supporting me open-heartedly. I really appreciate it. And I'm thankful. And you all are going to now, don't leave me. Work with me in 2025. Don't leave me on the roads. Thank you so much. Thank you.
Thank you, ma'am. Madam, we cannot leave you. This association is lifelong.
I know.
You will be Foxy president for 1 year, but you are our mentor and guide lifelong, ma'am.
Thank you, darling.
Yes, ma'am.
Thank you.
And so we move forward.
Lovely to see you, Rajan.
Rajul, ma'am. Hello, ma'am. You're muted, ma'am.
I know. And Rajul is moving also a lot. And Rande, my sweetheart, thank you so much. You always rock wherever you are.
So Dr. Randhir is one of the program coordinators, and we welcome him. And next we move to our introduction of our chief guest and our guests of honor. It is with great pleasure I welcome Dr. Rajul Tyagi from Lucknow, and we will be seeing a lot of Madam because she is going to host Lucknow ISAR for us in 2025, where we will all go to the city of Nawabs and we will get royal treatment from Rajul ma'am. I have seen Madam growing like from a person who was asking how CC works to now, you know, her daughter is studying blastocyst biopsy in Spain. She's in Spain, Madam, I think. So, I mean, Madam is astonishing. The passion with which she reads, the passion with which she discusses. She holds such high positions in ISPAT, UP chapter ISPAT. She is head of one of the biggest test tube baby center and hospitals of Lucknow, the Javitri Institute. She's headed the, she's been a member of the endometriosis committee of Foxy. She has been the board member of Bayer Zydus Mankind and secretary IHRF. Madam, without wasting time, we would like to have a few words of blessings from you. Madam, आप muted हैं. Madam, you're muted. Madam, you have to unmute. Yes.
Now I'm audible? Yeah.
Yes, ma'am. Yes, ma'am.
So good afternoon, everyone. And thank you very much to Monica, Dr. Randhir, and special thanks to my mentor, my friend, Dr. Sunita Tendulwarkar. She really, we know, she is going to take Foxy at sky heights. And after this, she has to take ISAR as in command also. So thank you very much. And this perfection series, Monica, is an excellent idea to giving a knowledge to everyone. And especially you are concentrating on each time one special topic, which is the need of hour. So thank you, Monica, and special thanks for me inviting as a chief guest. Thank you very much.
Thank you so much.
ISAR करनी है तो मुझे ISAR आप लोगों के कोऑर्डिनेशन और आपकी सपोर्ट के बिना नहीं है. एंड आई गिव स्पेशल थैंक्स टू रणधीर. रात के 2 बजे भी फोन करती हूँ, रणधीर क्या करना है? He will say, Madam, do this. So really, I am very thankful to all of you. Okay, thank you.
Madam, we will make Lucknow ISAR something we will remember. Will remember.
रणधीर मुझे ना शुरू से आगे तक गाइड करेगा. कैसे कुछ करना है, टेक्निकल भी एंड मॉरल सपोर्ट भी बहुत देता है. थैंक यू वेरी मच रणधीर. थैंक यू.
Thank you, Madam. Next, I invite our guest of honor. It is with extreme pleasure I introduce my dear colleague and friend, Dr. Anshu Jindal. Anshu and I, we have been associated last 15 years, where we met during our Ashray trips and have, you know, become great buddies. So,
Thank you, Monica.
Anshu also, I always knew her as a very dynamic person, very sweet, humble and dynamic person with a very great husband. But despite the popularity of Dr. Sunil Jindal, and, she does not let that popularity eclipse her. She has an aura of her own. She has a standing of her own. That is very important. See, if Randhir is popular, it doesn't mean people shouldn't know Monica also. So that is very important, that you should have a separate personality, a separate standing. So Dr. Anshu, she is the head of Jindal Hospital and Fertility Center, Meerut, joint treasurer of UP ISAR, editor of UP IAGE, and member of Infertility Committee of Foxy. She's been a gold medal postgraduate from Lady Hardinge Medical College with awards in various associations. She loves to write chapters, textbooks, loves to do ultrasound. She loves to do special cases. I remember your, the syndromes you have delivered, Swire syndrome and so many things. She
Yeah.
like, she writes in newspapers. Her column comes in Dainik Jagran, and I follow her on Insta and follow Facebook. She is very dynamic. Welcome,
Thank
Anshu.
you. Thank you so much, Monica. Such a pleasure seeing all of you, being part of this Perfection series, which I really love. And thanks to all the President Foxy, Dr. Sunita Tendulkar is the brain behind it. And you are conducting it so well because it's so detailed. It goes right into the perfection. And I'm really looking forward to today's session on multiple pregnancy, because you're going to discuss so many aspects of multiple pregnancies, which is so confusing to an obstetrician also, what to do, when to do. And I really congratulate both you and Dr. Randhir also for bringing forward this Perfection series. Naam hi itna perfect hai, so everybody I'm sure looks forward to this, and I have been a part of it in the past also, and it's such a pleasure to be a part of it today and being invited as a chief guest. All the best to Dr. Rajul Tyagi for holding the next ISAR, and we are looking forward to meeting all of you again in person as well. So I am looking forward to a very wonderful, evening today on multiple pregnancies.
Thank you so much, Dr.
My
Anshu.
video on multiple pregnancy, which was such a rare case, I don't know if you people have seen it. We did an IVF for this patient, and we transferred 2 embryos, but inside one of the embryos split into 2. So now she has triplets. She has a dizygotic twins with monozygotic twins in one sac. And
Yeah.
that video caught the fancy of the entire, I would say the nation or the world, because I have 2 million views. Till yesterday, we had 2 million views on that video. I will share the link with you, and I'm sure many of you have seen it also. So it really gives me great pleasure, because I have had a big experience in dealing with multiple pregnancies.
Thank you so much. And we would love to have that link in the group.
Yeah, I will send it.
All of us can, watch, and I will link it with the, YouTube of this session.
Anshu, can I say something?
Yeah.
When I have, 2-3 times in last 20 years, I have this, and Pooja Lodha is very much here, who is my fetal medicine consultant.
Yeah.
I have already gone ahead and done monochorionic twin embryo reduction at 8 weeks of pregnancy, only 7.5 weeks of pregnancy, and allowed only simpleton to go ahead in life. I have always done that, Anshu.
Dr. Sunita, we offered this to the patient, but she refused. She said,
Because singleton will be better than having these compromised
but
triplets.
we can't. She hasn't given her consent for it. She has refused. In fact, I haven't seen this patient for the past 1 month. She's refused to come and see me also, because she feels that I might pressurize her into reduction. She's refused. Point blankly, she's refused. So I cannot go ahead with it.
Okay.
Yeah, madam is right that because now I will, as you will listen in the panel and the talks, that monozygotic and monochorionic twins, actually, they can turn into nightmares. They can turn into obstetrician nightmares, which can lead the entire ART result into a mess, the patient into compromise, her perinatal period into a big nightmare. So it is best to counsel, but ultimately counseling is only counseling. You cannot pressurize for screening. You cannot pressurize for any aneuploid determination. You cannot pressurize for selective
anything. Absolutely.
You're right. And coming to our guest of honor again, Dr. Kanchan Sharma. Can I have a slide, please? Dr. Kanchan Sharma, she is the rising star of Foxy, because who doesn't know that she has won the election to the coveted post of chairperson, non-communicable diseases. And this was done with a lot of hard work and perseverance. We saw that energy in NatCon. And NatCon, I think Anshu was there, myself, I was there, Dr. Randhir, Dr. Sunil Jindal, Sunita Madam, Nandita Madam, Mahapatra Sir, everybody converged onto Kanpur. And Kanpur was flooded with luminaries, and the conference was a grand, grand success. I think that highlighted you like anything, Dr. Kanchan. And everybody wanted to vote for you. She is chairperson-elect NCD Committee Foxy. She has received the Foxy Achiever Award. She has been she is the current secretary of Kanpur Obs and Gynae Society, president IHRF Kanpur, and a keen ART specialist, laparoscopist, and colposcopist.
Thank you, Dr.
I welcome you, Dr. Kanchan, and we would like to hear a few words of blessings from you.
Thank you, Dr. Monica and Dr. Randhir. First of all, my sincere thanks and congratulations to the organizing team, to you and Dr. Randhir and all, the most respected, loving and blissful President, Dr. Isar, Dr. Nandita. She is not here at present, but she's very loving. Dr. Sujata Kar, the Honey Secretary General, and beautiful, loving, brilliant, foxy President-elect, Dr. Sunita Tendulkar. Madam, many words of appreciation from my side to you. You will definitely take our foxy to a different heights. And thank you for always with me. Dr. Monica and Dr. Randhir Singh are the co-conveners. Both are very cooperative, humble, loving, and laborious. I have great interactions with them, especially when they came to Kanpur for infertility workshop in WWNetCon and during the elections. Best wishes to Dr. Monica for your future endeavors. Dr. Shabana Sultan and Dr. Purnima Tiwari, both program coordinators, have put much of efforts to organize this webinar. Congratulations to you. Topic chosen are excellent. These are multifetal gestation, latest prospective. Speakers, Dr. Pooja Lodha, Dr. Anjali Khare, Dr. Divya Singh, all the learned chairpersons. And moderator of the panel, Dr. Monica Singh and Dr. Manupriya, and all the wonderful panelists. My good wishes for this successful webinar, and thanks to organizing team for giving me privilege, and thank you our chief guest of the day and Dr. Anshu Jindal. Thanks organizing team again.
Thank you.
Thank you, Dr. Kanchan. That was so
You are not
such a sweet
any
message
regular
from
class.
our side.
Maybe
Now, without this,
bound to
because
say.
we are about to reach 4:30, and 4:30 we have
ये
to
students यही है
I hand over the program to my program coordinator,
अब
my
देखो भाई ये तो मैंने खुद देखा है कॉलेज
gynecologist from Bhopal, Dr. Purnima Tiwari, whom I'll introduce in a few words. Is Dr. Shabana there? Has Dr. Shabana joined?
I think ma'am has not joined yet.
So we'll introduce her later, but Purnima, everybody knows from perfection, P for Purnima, P for perfection. So she has recently joined as consultant Apollo Sage Hospital, which is a big corporate. So she'll turn into a posh ART specialist, and we'll be taking appointments from her. But that was just, a little bit of joke. Otherwise, she's a very brilliant alumnus of Maulana Azad Medical College, Delhi, received several fellowship awards and done a lot of, paper poster presentations in national conferences. And I wish her all the best. She is my program coordinator, not only for ISAR Perfection series, but also Foxy Symbiosis series. Welcome, Purnima, and please start session number 1.
Thank you so much, ma'am, for kind introduction. So I would like to invite our chairperson for session 1. Our first chairperson is Dr. Sapna Bajaj, ma'am. Can I have the CV, please? Dr. Vishal, CV slide. Yes, Dr. Sapna ma'am is Director Obstetrics and Gynecology Service in Sagar Multi-Specialty Hospital, ex-Professor Obs and Gynae. Worked in CHL Apollo Indore, Apollo Sage Bhopal and Birla Hospital. Ma'am has received lap and urogynecology unit, Basildon University Hospital, London. Having area of interest, vaginal surgery, scar-free hysterectomy. She is having many publications in prestigious journal. And she is very good teacher and guide for medical students and author of the book NEET PG 123, 19 Methods to Crack NEET PG and INI CET, and she has been awarded Dr. Jogeshwari Mishra Prize Best Poster in AICOG 17 and a special prize for innovative idea in gynecology IMS 2019. I welcome you, Dr. Sapna ma'am.
Thank you,
Sapna ma'am,
Thank you very much.
thank you ma'am for joining us today. Yes, our second person is chairperson is Dr. Archana Mishra ma'am. Ma'am is the state program officer, maternal health, National Health Mission, Government of Madhya Pradesh. Ma'am is very brilliant alumna of GMC Bhopal. Ma'am has done undergraduation and post-graduation with laurels and then subsequently joined State Health Services and has conducted various state health activities with MP government. We applaud all the hard work and dedication toward health by Dr. Archana Mishra ma'am. We welcome you ma'am. We are honored to have you on this platform. Dr. Archana ma'am, are you there? Have you joined us? I think Dr. Archana ma'am has not joined us yet. So I would like to invite our chairperson for introduction of our next speaker, Dr. Pooja Lodha. Sapna ma'am, can you introduce our speaker?
Yes, please.
Thank you.
Dr. Pooja Lodha. She is a fellow fetal medicine from certified UK Fetal Medicine Foundation. She is working with Dr. Sunita Tandulwadkar in her setup of Kangaroo Care, the Fetal Care Clinic, state-of-art fetal medicine center in Pune. Lead consultant fetal medicine and fetal therapy, Ruby Hall Clinic and Bharatiya Vidyapeeth Medical College and University Pune. Southeast Asia Ambassador, Bloom International FIGO Fellowship, and faculty trainer for Maharashtra University of Health Science Fetal Medicine Fellowship KM Pune, 1 year fellowship in Materno-Fetal Medicine, Bharatiya Vidyapeeth Medical College, University Pune. Dr. Pooja has done POGS Dr. Kamath Award for Best Paper 2023, Indian Medical
Thank you so
Association.
much, ma'am, for the kind introduction. Thank you, ma'am.
But you have a lot of achievements.
Ma'am, just bless me for more. Thank you very much.
Welcome, Dr. Pooja. Welcome.
Thank you, ma'am. With your permission, can I share my slides, ma'am?
Yes, yes, please. Please go ahead.
Is the slide visible?
Yes.
Respected dignitaries, Dr. Nandita Palshetkar ma'am, the brainchild behind this series, along with Dr. Sunita Tandulwadkar ma'am and Dr. Sujata Kar ma'am. Special thanks to Dr. Monica Singh ma'am and Dr. Randhir Singh sir. And Dr. Purnima, thank you for all the coordination for all these days. It seems to be an amazing 3 hours of academic feast. And thank you, Chairperson Madam, for the kind introduction. Today, I would speak on the 12 weeks Pandora's box, all you need to know about twins. And before I start, I would want to tell you that my Pandora's box is here. She is busy consulting in the OPD. We can see her, but ma'am can't hear us. Sunita ma'am, I think she wouldn't be able to hear us, but she is my Pandora's box. And everything that I am today, I owe it to madam. So I've known ma'am for over 15 years, and she is the one who's given me vision for fetal medicine because of all the high-risk obstetrics that I have seen with madam. And I thank her, and I dedicate this presentation to madam, and thank you for this opportunity too. So today, over the next 30 minutes, we are going to discuss some very basic, it appears basic, but as I always feel that when things go wrong, we think about what we could have done differently, and it's usually the basics where we go wrong. And if we follow these basics, then twins becomes relatively easy. So we will be talking about determining chorionicity in twins, labeling of twins, predicting complications, and aneuploidy screening. I will try to limit my presentation to 12 weeks because I see the next two amazing speakers and the panel who would cover the rest of the aspects. Now, this was in 2011, the largest study that was done, and the whole map was shown as to what the incidence of twinning is. And we can see that India is in the yellow zone, which means that the twinning in India is supposed to be 9 in 1,000 twins. But we all know we cannot agree with this number because we all are seeing so many twins and triplets every day now. And the prevalence of multiple gestation globally at present on an average is 32 per 1,000, which is huge. And India is almost at the peak there. It is 30.5 per 1,000 deliveries. And yet we don't have a registry. We do have an ICMR registry, but all of us don't report twins there. So the numbers there are actually underrated, and the incidence and prevalence of twins is rising hugely. Thanks to the ART techniques and more number of women conceiving after the age of 35 also. Madam was just telling us about this Helen's rule that we have studied in Williams while we were doing our PGs, where it said that the incidence of twins is 1 in 80, the incidence of triplets is 1 in 80 to the power 2, quadruplets is 80 to the power 3, and so on and so forth. But this whole Helen's rule has been skewed by the artificial or the assisted reproductive techniques, and we will see how. So is it really good news? All of us who scan or who break the news to couples who have conceived with IVF or ovulation induction, and the couple is so excited with the news of twins and triplets, and it's actually very filmy in a way for them that, wow, we are going to have twins and both the babies are going to grow up together. But as clinicians and caretakers, you and me know that it's not great news to have twins, and the risks associated with twins are way more than a singleton pregnancy. And there's more read in between the lines to what I've just said. So as soon as the news of twins is broken, the first thing the radiologist, the gynecologist, and the fetal medicine specialist will put their heads into is the type of twins. And we all are always wanting to run off with that topic. We use words such as similar twins, dissimilar twins, fraternal twins, zygosity, chorionicity, and so many big words keep coming up. And hopefully by the end of today's talk, we all will be on one page how to simplify calling what twins they are. So this is what we've read in Williams, and I'm not going to repeat this because this is absolutely confusing how much ever simple it looks. And the good news is that it does not need to be remembered. Okay, so this is not important. Which is more complicated is zygosity. Which is more important, fortunately, is chorionicity. And chorionicity is way more simpler than zygosity. So I could even say that from today onwards, we all can do away with the word zygosity completely. It just simplifies things, because if we all are on the same page internationally, even nationally, it's easier to counsel patients, it's easier to form guidelines, it's easier to call them back for follow-ups, it's easier to deliver them at the same time. And rather than using various other terminologies, if we stick to one, we all will be on the same page to even counsel patients, which becomes much more easier. So yes, the good news is you can totally forget about zygosity. And why is chorionicity so important? Why all the hue and cry only about chorionicity? Because you can see on the screen there, the list of complications like miscarriage, perinatal death, fetal growth restriction in one or both the fetuses, preterm delivery before 32 weeks, which has a lot of morbidity and mortality associated with it, and major birth defects are significantly higher in monochorionic twins as compared to dichorionic twins. Okay, so this chart is very clear why we are worried about chorionicity. Now, when we talk about chorionicity and we find out that the set of twins is dichorionic, we are as happy as we would be if we would have had a singleton pregnancy. Whereas if we find out that this is a pair of monochorionic twins, all the complications run through our mind, and a spectrum of special caretaking for this couple now starts, which we will go through. So coming to the type of twins, and this is a very simple apartment analogy that I have been successfully using for the last 13 years. And I've been trying to convince all the obstetricians to talk to your patients only in this language. So once you get a report from your sonologist or you scan yourself and there are twins, you make sure, number one, that there is no report as 7 weeks twins. it has to mention the type of twins. If not, send the couple back to the radiologist, give them a call and say, never ever again do you please report my patients of twins without a chorionicity. Okay, because everything that you're going to tell the couple will depend on what type of twins they are. So there is no report like twins. It's either a monochorionic or a dichorionic twins. Okay, now what is this apartment analogy? It's very simple. In one apartment, there are 2 rooms, 2 kitchens, and 2 different people living, one in each room. Okay, so one has its own room and kitchen, another has its own room and kitchen, and they do not interfere with each other's lives whatsoever. What is this type of twin? Yes, it is a dichorionic, diamniotic twin pregnancy. Okay, so this is fortunately the commonest type of twins that we have. And most of the ART conceptions, which are twins, are dichorionic, diamniotic twins. Okay, so this is the good news, the good kind of twins that we have. Now what next? The problem starts. एक घर है, 2 room है. They are not sharing the room, but they are sharing the kitchen. Now the whole problem starts with this kitchen, because if there is a scarcity of food supply later, one of them is going to be more opportunistic and take away all the food, and the other is going to suffer. Okay, because they have only one kitchen to share from now. And this complication that I'm talking about is twin-twin transfusion syndrome and selective fetal growth restriction, which typically happens in monochorionic twins because they are sharing the kitchen. And by kitchen here, I mean the placenta. Okay, they share the anastomosis. There is a common placenta, and everything is a fight between both the twins if placentations do not happen properly for both of them. For similar reasons, if there is a food poisoning in this kitchen, so imagine there's only one source of food, and if that is poisoned, both the babies are going to be affected, not one. Okay, versus a dichorionic twin, if one of the kitchen has poisons, it will harm one baby, but it will not affect the other baby at all. I'm talking about an IUD, I'm talking about a fetal reduction, which can easily be done in a dichorionic pregnancy because they have different kitchens. In a monochorionic pregnancy, you cannot put in KCL in one of the babies because that is going to intoxicate the other baby through the common placenta. Okay, so food poisoning in the kitchen will affect both the babies. IUD in one baby likely to affect both the babies because they have a common placental sharing. This is monochorionic diamniotic twins. Now, further to complicate things, there is a third set, fortunately the least common of them all, where they live in an apartment, they share a room, and they share the kitchen. So now, of course, they're going to fight for food. But apart from that, they also have limited living space, which means there is going to be a lot of jhagda between them and a lot of entanglement, which will then come to the problem of cord entanglement and sudden IUDs, which is more common in monochorionic, monoamniotic pregnancies. Fortunately, these are the least common of all, and therefore we do not come across them very commonly. So is this very clear? One house, 2 rooms, 2 kitchen, dichorionic, diamniotic. One house, 2 rooms, 1 kitchen, monochorionic, diamniotic. One house, 1 room, 1 kitchen, monochorionic, monoamniotic. Okay, so in this way, if we all talk to each other and our patients, they understand very well why we need to see the monochorionic twins every 2 weekly after 16 weeks, because they are sharing the placenta. We need to monitor for twin-twin transfusion syndrome, for selective fetal growth restriction, which are not complications of dichorionic twins, and therefore the surveillance of dichorionic twins can be as much as a singleton pregnancy. Okay, so coming to how to screen twins in pregnancy and what all to see in each trimester. On an early scan at 6 to 8 weeks, of course, you look at the number of fetuses, you look at the chorionicity. Now, a lot of us feel that greater the gestational age, better is the chorionicity. That's a myth. The best chorionicity that you can see is before 11 weeks. Okay, the best time to know the chorionicity is between 8 to 11 weeks. And therefore, if a couple comes to us for the first time for a scan with twins at 28 weeks, and the earlier scans do not mention the chorionicity, we just go back to the 8 weeks images, and the image itself will tell us whether this is a dichorionic pregnancy or a monochorionic pregnancy, because the whole delivery process and everything will depend on what chorionicity it is. So therefore, remember, early scans should document chorionicity. Yes, you look for the membrane in between the sacs, and you look for amnionicity as well. You label the twins systematically, not as early as 8 weeks, but on the NT scan, we'll come to that. And is 6 to 8 weeks the dating scan? It's actually not the dating scan, not just for twins, but even for singleton. Remember, it's very difficult to measure, to locate the crown and rump of the embryo at 6 weeks. And therefore, the CRL at 6 weeks is not as accurate as it will be at 12 weeks during NT scan. So if this is a spontaneous conception where there is a difference of more than 1 week between the LMP, gestational age by LMP, and gestational age of the embryo, you date her only at the NT scan and not at 6 weeks. Because I may feel anything white and echogenic is the crown, you may feel it somewhere else, and a few millimeters at 6 weeks can cost us a whole week later for dating. Okay, so yes, write that this is a delayed conception, and the final EDD will be assigned during NT scan. The ISWA guidelines support this. We have a speaker speaking on ISWA guidelines, and we date the pregnancy according to the CRL at between 10 and 14 weeks, only if there is a discrepancy. Now, this is an ISAR webinar, and I have to specially mention about the ART conceptions. We never redate IVF conceptions, okay? Because in an IVF, when you are doing an embryo transfer, you already exactly know the age of the embryo. So if it's a day 3 transfer, it's 2 weeks and 3 days. Day 5 transfer, 2 weeks and 5 days. And that's the way you calculate, okay? So on the day of embryo transfer, the embryo is already 2 weeks and 3 days. That's the way you calculate dates for an ART conception. And irrespective of the difference in CRL and the dates, you never redate an IVF pregnancy, okay? So let's start with the early scan. You look at the number of gestational sacs, you look at the fetuses, especially when this is an IVF conception or even an ovulation, induction and follicular monitoring. Once you see a sac and an embryo, do not stop there. Contain your happiness, look for another sac. You don't find it, contain your happiness, look for an ectopic, because heterotropic pregnancies, twins, triplets are very common amongst ART pregnancies. And once you find the number of gestational sacs, go and look for the number of yolk sacs, the number of embryos, and that's how we go about it. Now, there are exceptions to every rule, but I would say this is beyond the scope of this talk particularly. For this talk, the number of gestational sac is equal to chorionicity. There are 2 gestational sacs with a good chorion in between. It is a dichorionic pregnancy. Okay. There are 2 yolk sacs. It is a diamniotic pregnancy. So number of gestational sacs tells us about the chorionicity, and the number of yolk sacs tells us about amnionicity. There are things like single yolk sac with twins and double yolk sac with singletons. But like I said, these are all exceptions. 99% of times you will be right when you follow what's on the screen right now. So let's look at some images here. On the left here, we see that there are 2 gestational sacs, and there is a very good decidual reaction and a thick brim of tissue between the 2 sacs. So this is very clearly dichorionic, diamniotic twin gestation. Okay. Now you look at the second image here. There are two embryos and 2 yolk sacs that we can see, but you see that there is one thick chorionic sac outside. Okay, so surrounding both the embryos, there is a common chorionic decidual reaction, and each embryo is surrounded by its own thin amnion that you can see here. It's labeled as amnions. Both have their own yolk sacs. Like we said, 2 sacs, 2 yolk sacs, a single gestational sac. This is a monochorionic diamniotic pregnancy. Here we see there is a single decidual reaction. You can see only a single yolk sac, not very clearly seen here, we'll come to that. But there is a single amnion which surrounds both the embryos. Okay, so When you see a single yolk sac and you see a single embryo, do not stop there. Go circumferentially around the yolk sac to check if you see another embryo, because that's how monochorionic, monoamniotic pregnancies will look like. Okay, it's a Mickey Mouse appearance where you see a yolk sac and 2 white echogenic embryos on either sides. So this is a monochorionic, monoamniotic pregnancy. When in doubt, call her in 2 weeks. A lot of things change. Okay, especially when you don't see a membrane between the 2 sacs, do not call it a monoamniotic pregnancy. Write that this is definitely a monochorionic pregnancy because you can see only 1 gestational sac. But I would want to see her back in 2 weeks to make sure if this is a diamniotic twin pregnancy or a monoamniotic twin pregnancy, because sometimes the membrane is so thin that you may not be able to see it at 6 weeks. How do you determine chorionicity later if she is coming later? There are various ways to do it. If there are 2 separate placentas, one anterior, one posterior, this is definitely a dichorionic twin pregnancy. Okay. But if there are both the babies have got an anterior single placenta, it does not necessarily mean that this is a monochorionic pregnancy. Now the kitchen is the same. I told you that the kitchen is the same. In a dichorionic pregnancy, if both the babies have implanted their placentas anteriorly, it will look like a fused anterior placenta, but it is actually not fused. It's just that both of them have implanted their placentas anteriorly. They are 2 separate chunks close to each other. 2 different kitchens, but just very close to each other. So a dichorionic pregnancy can also have a common anterior placenta. Okay. Whereas if you find 2 placentae, you are definitely sure that this is a dichorionic pregnancy. We cannot use gender in India to substantiate what kind of pregnancy this is, but all the practicing fetal medicine specialists who are listening know in our minds that situations can be confusing when we really want to label it well, and we do use gender for our own notes, but do not, of course, mention it on the report. And it is really helpful sometimes in later gestational ages to find out whether this is a monochorionic or a dichorionic pregnancy. Lambda sign and the twin peak sign, this is very typically seen that we saw in the previous images, and it could be helpful. Now here we see on the first image that one placenta is anterior, another is posterior. So this is definitely a dichorionic diamniotic pregnancy. In the middle one, although both the placenta are on the same side, right laterally, you see a proper lambda sign, a lot of chorionic tissue dimpling inside in the membrane between the 2 babies. And this is also a dichorionic twin pregnancy. Whereas the third one, we see a common anterior placenta, whereas there is a very thin membrane separating both the babies and no placental tissue is dipping into the membrane, and it's a clear-cut T sign there, which is the monochorionic diamniotic twin pregnancy. So here is how on the right side there is monochorionic and on the left there is dichorionic. For triplets, we have this typically Mercedes-Benz sign where there is an inverted Y kind of a picture. And something that I have not read anywhere, but I find it useful. 3D actually helps. If there is a very thick membrane between both the babies, then we can be really sure, like the first image there, which is a dichorionic pregnancy, and the one below here, which is a monochorionic twin pregnancy, because it's very clearly a T sign with a thin membrane between the babies. Now coming to one of the aspects, which is systematic labeling of twins. It's very important that we label the twins properly, because we are doing aneuploidy screening. We are going to screen them for growth. We are going to do fetal reductions. We are going to decide which one needs an amniocentesis. There are so many reasons why we need to know, why we need to label the twins properly. Now, something that is important is that once you have labeled the twins at NT scan, do not change the labeling, irrespective of whether you are scanning her again and again or somebody else is also scanning. Try to stick to one labeling, because the growth charts later will reflect very beautifully if you have maintained the labeling. If one of the babies is growing normally and one of the babies is tapering in growth and showing a fetal growth restriction, it will be very difficult if you do not label the same babies every time on ultrasound. Okay. The twins pregnancies, they are at an increased risk for discordant anomalies, aneuploidies, growth restriction, and therefore it is extremely important that we label the babies correctly. Now, what was happening for all these days is that we were labeling them just to the proximity of the cervix. For example, near the internal os and away from the internal os. But soon the ISWA guidelines came in and they said that if we label only by near the internal os and away from the internal os, 10% of the babies are going to show us something known as a switch phenomena, where your labeling will go wrong. So if you just see this image here, there is a membrane separating the babies. Now the baby on the right is near the baby on the right from the internal os, and the baby on the left is near the internal. After a few, identify which is our fetus 1 and which is our fetus 2, because the orientations also will change from vertical to horizontal, and therefore near the os and away from the os will go wrong in these 10% of the cases. Hence, we now use a lot of criteria to label the twins. If the placenta is anterior and posterior, no question, we label them that way and we go on like that. But if the placenta is on the same side, this is how you use to label. Near the internal os, maternal right, vertical top bottom. So you use all three to label a baby so that you don't go wrong. And using this method, then you will end up having the correct labeling every time. Okay. So we've already gone through the dating. Yeah. Now, a discrepancy in the growth, what can it indicate in twins during NT scan when you are doing a scan? If there is more than 95% discrepancy between both the babies, it may indicate that the smaller baby is evolving some anomalies which are not seen today. There are aneuploidies in the smaller baby, or you need to do a selective fetal growth restriction. If there is a huge difference in one CRL is 70 and another is 47, you need to be really sure, because more often than not, the baby with the smaller CRL is going to have some or the other problem coming up later. And very importantly, in monochorionic twins, if there is a discrepancy in CRL, in NT, you have to monitor her very closely for twin-twin transfusion syndrome and for selective fetal growth restriction. Okay, so I will come to the aneuploidy screening in twins. Now coming back to the apartment analogy, very simply understanding, a lot of us don't do a double marker in twins. Please go ahead and do it, because you will not be able to do a quadruple marker in twin pregnancy because the false positive rate is very high. So the ideal way to screen for Down syndrome in singleton is to do a good NT scan, nasal bone, nuchal translucency, ductus venosus, and regurgitation, and in this ultrasound double marker. This is exactly what you do for twins as well. What is the difference? In a dichorionic, diamniotic twin pregnancy, the kitchens are different, the placenta are different, the genetics is different, and therefore you will get two separate risks, one for each baby, depending upon the ultrasound markers of that baby. So if one baby has an NT of 3.4 and another has an NT of 1.2, despite both of them having the same double marker in the mother, the baby with the higher NT will have a higher risk, and the baby with normal NT will have a lower risk. This is what happens in dichorionic, diamniotic pregnancy. The risk is per fetus. Okay. What happens in monochorionic pregnancy? They have a common kitchen. They are sharing all genetics. And therefore, if one baby has a chromosomal abnormality, the other will also have a chromosomal abnormality. There are exceptions. We won't go there. Therefore, when you give double marker for a monochorionic twins, your lab should be accredited enough to ask you what type of twins they are, because their reporting will depend on your type of chorionicity. Okay. Once you mention this is a monochorionic twins, they should give you risks per pregnancy and not risk per fetus. So although the NTs will be different for both the babies in monochorionic twins, the lab should give you only one risk per pregnancy, because whatever is happening with the genetics of one baby, the same is going to happen with the genetics of the other baby. Okay. Therefore, it's very important that you mention on your form what type of twins they are. So yes, we have discussed that markers like nuchal translucency, tricuspid regurgitation, and ductus venosus, these are extremely important not just for aneuploidy screening, but to predict complications of TTTS, cardiac anomalies in monochorionic twins as well. Okay. So I think I will stop here because the rest will be taken over trimester wise by the next speakers. And I would like to end by this slide where beauty lies in originality, but change is the only constant. Technology is a boon when used judiciously in aptly indicated cases, with proper interpretation without compromising on what is inevitable. What is inevitable is chorionicity. What is inevitable is a basic good NT scan. Okay, you don't need to jump to rocket sciences like NIPTs and invasive just because we know that it is available. The basic, without compromising on what is must to be done, should how the technology should be used. And my favorite slide for all those who scan, no job is finished until the paperwork is done, whether it be anywhere, and it holds true for PCP and DT as well. So anytime you touch your patient to the sonology, the ultrasound machine, please fill up your F forms. Thank you very much for a patient listening.
Thank you, Dr. Pooja. It's a very elaborate talk, and I think you have made it very simple. So we all have to remember that chorionicity is the must. We should look for and we should ask for. Thank you very much.
Thank you, ma'am. Thank you so much.
Thank you, Dr. Pooja. That was so beautiful. I mean, the analogy of the apartments and the kitchen means I thought apartment, but I never imagined the kitchen would be the placenta. Because now I have to conduct a panel, it will become so easy, asking questions.
Yeah.
And just one question I wanted to ask you is a vanishing twin.
Yeah.
Suppose under 6 or 7 weeks of gestation, well before the NT scan, if one of the sacs in our ART conception, the fetus does not, it completely disappears. Then doing a serum biochemistry for a first trimester screen, a combined test, would it hold true or would it be an erroneous result?
Thank you, ma'am, for bringing this up because we face this a lot of times. If the fetal pole or the embryo is visible on NT scan, do not do biochemical screening because the fact that there is embryonic tissue, it is going to erroneously impact the PAPA values, and we will have a false negative risk for Down syndrome, which is very scary. So if you see an embryo on scan of the vanishing twin during NT, do not do a double marker, do only an ultrasound screening. And if the sac is empty, there is no fetal pole, the demise happened more than 4 weeks prior. So many, there are sacs stop the heartbeat at 6-7 weeks itself. Then by usually such babies will not be seen, such embryos will not be seen by NT scan, and they will in empty sac. In this situation, you can give a double marker, ma'am.
And what is your opinion of an NIPT? NIPT for twins?
NIPT for twins has now been...
it's a big answer for you, but can you summarize it for our audience? Because there are so many queries about whether we can do NIPT in DCDA twins or MCDA twins. DCDA is okay, but are there any current guidelines which are favoring NIPT as of today?
Am I audible?
Yes, your internet is, internet is unstable in between, Dr. Pooja, but you are fairly audible, but right now it's creating a problem, your net, I think. If you can switch to data, if you can switch to some, your, probably data on your laptop or something.
Can you hear me, ma'am?
No, Dr. Pooja, your voice is breaking. The internet is not good.
Can you hear me?
Yeah. We can.
I think we can ask questions afterwards then, if
Yes,
Yeah,
yes,
I
ma'am.
think so.
yes. So Purnima, we move to session 2, and then at the end, we can ask all our speakers to answer our questions.
Yes, ma'am. Yes, so for session 2, I would like to invite our chairpersons. Our first chairperson is Dr. Varuna Pathak ma'am. Ma'am is Professor Obs and Gynae, Ramakrishna Medical College, Bhopal, having more than 20 years of experience, having area of interest in high-risk pregnancy. And she is Chairperson, Women's Wing, IMA Greater Bhopal, has been ex-Vice President of Bhopal Obs and Gynae Society, ex-Secretary Bhopal Obs and Gynae Society, presently Executive Member of IMA Bhopal, and she has received Gold Medal in Biochemistry, Honours in Anatomy, Biochemistry, Obs and Gynae, and she is an alumni of Agra Medical College and was awarded Naval Kishore Gold Medal for the same, and postgraduate diploma in clinical research, Symbiosis Pune she has done. I welcome you, ma'am, on this platform. Dr. Varuna, ma'am, thank you for joining us, ma'am. Now our second chairperson is Dr. Swati Sharma, ma'am. Ma'am is Professor, Department of Obs and Gynae, Mahavir Medical College, Bhopal. Ma'am is an alumni of SMS Medical College, Jaipur, has received various POXI trainings like in basic infertility, ultrasound, basic gynae endoscopy, ETHI skill course, FCCS training. She has been trained in basic course in biomedical research, has completed ESOP training, and has various publications in Indian journals. She is member of various societies and has participated in many CMEs, having area of interest in gynae laparoscopy and high-risk obstetrics, and is presently Joint Secretary Bhopal Obs and Gynae Society. We welcome you, Dr. Swati, ma'am. Thank you for joining us, ma'am. Now, I would like to invite our chairpersons for the introduction of our speaker. Yes. Dr. Varuna,
Thank you, Dr. Purnima. Thank you so much. Well, Bhopal Obs and Gynae Society needs no introduction to Dr. Anjali Kanhare, ma'am. She's been the ex-president to our society. Madam is a favored fellow from Mumbai. She's currently the professor and head of GMC at Chennai Medical College. Madam has a few awards to her, like the Jagdishwari Mishra Best Poster Presentation. Ma'am has been the Best Professor in Obs and Gynae Award, received the Best Professor in Obs and Gynae Award by World Education Congress at Bhopal Education Leadership Awards 23. Ma'am's special interests are in high-risk pregnancy, medical education. So we welcome Dr. Anjali Kanhare, ma'am, to give her deliberation today.
I take this opportunity to personally welcome Dr. Anjali and thank her for accepting my invitation to be here. And we love listening to her talks anyway. So today we're going to have a great talk again. Anjali, ma'am, you're muted right now.
Thank you, Dr. Monica, for giving me this opportunity. It's a wonderful platform which you all have started. And I'm so glad to be on this platform and seeing Purnima, Swati, Varuna, and all other stalwarts of obstetrics on this platform today. Just give me a minute so that I can start with my presentation. First of all, let me congratulate the ISAR team for starting with this Perfection series. And I think it is a very novel idea on your part, Monica, and on Randhir's part to put all the things together. It is just not the infertility part which you are taking care of. So kudos to you to have such a novel idea. Definitely, my thanks go to Dr. Nandita Palshetkar madam, to Dr. Sunita Tendulwar madam, to Dr. Kar, and your whole team for making you as the leader from Bhopal to start with this Perfection series and make a national impact. We all are there with you in this endeavor. Definitely, it was a wonderful talk by Dr. Pooja, and being a medical teacher, her apartment concept was very unique. I have been listening to multiple pregnancies for quite some time now on various platforms. It was on FMF platform, it was on other platforms also. And so far,
I would like to acknowledge this to Dr. Pooja that no one has come up with this apartment concept, which you have so well told today, and maybe teaching our undergraduate students are much easy with this platform and tell them why we are so bothered about the twins as soon as we get them. So she has already told you the percentage of twins, and we all are aware that with IVF procedures going on, there is definitely an increase in number of twins which we come across. They represent almost 3% of all pregnancies, and 30% of successful IVF procedures are with multiple pregnancies. She has definitely told you about the Helen's law also, so I'll not reiter that. But why are we so bothered about twin pregnancy? It is the mother as well as the baby. Multiple pregnancies are associated with three and both mothers. Maternal mortality is very high. It is 2.5% high. And the perinatal mortality increases from 50 to 100 births of twins and 100 to 200 per 1,000 births for triplets. So if we can see, I already told you about the monozygotic and dizygotic twins, and she has very wonderfully explained why it is more significant. Monochorionic, monoamniotic are less than 1%. Monochorionic, diamniotic are almost 75% of the monozygotic twins, and dichorionic, diamniotic are 25%. We are more bothered about the monozygotic ones. I'll not go ahead with her apartment concept explained so well. Maybe next time in my slides, I'll use her concept with her permission and probably change this slide into that particular slide. There are various factors which affect the dizygotic twinning, like the ethnic group, the increasing maternal age, increasing parity, if you have a family history of twinning, especially in mother, and as rightly said, if there is the patient is on ovulation induction or under treatment for infertility issues. There are n number of maternal complications which are there in all the three sectors of pregnancy. There could be pre-pregnancy complications also if you are associated with infertility. When the patient conceives and you come across that she's having twins, or even before you come across that she is having twins, you can come with she can present to you with complications of hyperemesis, polyhydramnios, preeclampsia, anemia, hemorrhage. During intranatal period, she can come as a malpresentation, dysfunctional labor, increased chances of operative delivery, a postpartum hemorrhage, retained placenta. And as obstetrician, many times we miss on the postpartum complications, which are difficult to cope up with twin kids, physical demands, the demand of breast.
I think ma'am got disconnected now.
Must have been some, because it's raining here in Bhopal, you know.
Yes,
So
yes.
maybe it's the internet issue or electricity.
I'll call her. I'll call her.
Ma'am has joined again.
Okay.
Okay, good.
Anjali ma'am, your internet is a little unstable. You're muted, Dr. Anjali. You're muted. Please unmute.
Must have been some electricity issue for all we know.
Sorry for that. Yes, I'm on the outskirts. Am I audible now?
Yes,
Yes,
you're
ma'am.
right. You're right.
Yeah, so there is a issue, light is flickering, and as I'm on the outskirts of Bhopal, I've just reached home and the presentation was also not picking up. So I hope that it should work out now. So I was talking about the postpartum complications, which many times, as an obstetrician also, we are a bit late to probably pick up. And so many times we think that, okay, it's a part and parcel of being postpartum phenomena, but one needs to be aware about it. In even singleton pregnancy, it is, I guess it is on rise, and with twins, it is sometimes very difficult to undergo the treatment part also because of the increasing demands.
Anjali ma'am, your screen is not visible.
Yeah,
Sorry,
just a
ma'am,
minute.
your slide, have you shared your slide, ma'am?
Yeah, I did. Now is it visible?
No, ma'am,
No,
it's
slides are not
So-
visible, ma'am.
So just give me a minute because I think because of that light issue, my thing has gone out.
We're still seeing you, not the slides.
Just a minute. Give me a minute. I'll restart.
Need to slide
I
share.
think that has moved out of the sharing part. Just a minute.
Yeah, take your time, Didi. Take your time.
Yeah.
Anyway, the webinar is for 3 hours, so we have a lot of time. We can even chat in between.
Yeah, you can carry on with that, Monica. That will be great.
We all are from Bhopal, ma'am, right now on this screen, I guess.
Dr. Pooja has left. Dr. Pooja has left.
Yes, Dr. Pooja has. No,
No,
no.
Dr.
She's there, ma'am. She's there.
I wanted to ask her the NIPT question. Then that
Dr.
would be in
Pooja, are
my.
you there?
Dr. Pooja, are you there? I can see Dr. Pooja. Yeah, I can see. But Dr. Divya is also there. Dr.
Monica,
Divya.
I'm not able to join in. Just give me a minute.
No, Didi, please take your time.
Yeah, you can carry on with the discussion in between.
Dr. Divya, are you there in the meeting? Dr. Divya Singh, are you there in the meeting?
Dr. Divya.
Dr.
Yes,
Divya Singh
maybe.
has joined, but I think she must be just logged in. She is not present at present.
In the meanwhile, can we complete the NIPT question?
Yes. I was looking for you
Sorry.
actually, Pooja. I thought you were seeing a
Sorry,
patient.
I'm so sorry.
No,
Something
no,
went
it's
wrong.
okay. It's okay. Yeah, I would
So-
love to hear the NIPT thing. Yeah.
NIPT can we switch off the screen sharing for a second? I can't see anything.
No, Dr. Pooja,
I'll
let-
again have issues. Then you go ahead. I'll
Okay.
not talk. I'll just
So
share the screen and
NIPT
I'll
has
wait for
now
your
been
answer.
validated for twin pregnancies as well, but dichorionic twins are more validated as compared to monochorionic twin pregnancies. Having said that, it is still safe to do NIPT in monochorionics because we know what happens with one happens to the other. And if there is high risk, you have to sample both the babies any which way. If there has been a fetal reduction or a vanishing twin, you cannot do an NIPT for 6 to 8 weeks after this. Okay, so suppose you do a fetal reduction at 11 weeks for whatever reasons, and you need to do an NIPT, you do it after 6 to 8 weeks. You cannot do it before that.
Right.
As for NIPT as a general screening, if you are assorting to that, yes, it is the best screening test. It can never replace NT scan. You have to have an excellent NT scan. Do an NIPS from an accredited genetic lab. Everybody is doing everything. I mean, we all know what I'm saying, but if we are putting in that amount of money from the patient, it has to be worth it. So NIPS has to go into an accredited lab. And yes, a lot of centers have gone to doing NIPS with an NT scan, especially in an ART conception, because these are precious pregnancies and elderly mothers. As for us, Sunita ma'am is not in the group, but ma'am always mentions that our screening rates are to the tune of 97% with a double marker and a good NT scan. And with NIPT, it's just going to be 2% more at the cost of a lot of cost. So we are still sticking to double marker with a thorough NT scan, and we do it very in a very specific way, and we are audited by the Fetal Medicine Foundation. We keep doing it every year. We are under audit of somebody. We know someone's watching, so we do it properly. That's about it. But yes, for elderly mothers, we make them aware that NIPS exists so that tomorrow the couple should not come up and say that we were not aware there is a test like that.
Yeah, thank you. Thank you so much. That
Thank
made
you.
it. Anjali Didi, are you ready with the presentation again?
Yeah, just.
Yeah, now you can start sharing.
I don't know what is happening. Just give me a minute.
We are on the last slide. Yeah, now it has come, Didi. We are on the first.
Let me just try, because as soon as I start sharing screen, my screen is going black.
Okay.
So I really don't know why it is happening.
So, Didi, can we, if you want, can we?
Yeah. Yeah,
can we
you can go ahead. Probably just give me a minute if I can probably see why this is happening. But as soon as I'm trying to go on the PowerPoint presentation,
Okay.
it is just.
You have Devashish at home?
Devashish was there, but now he has taken the dog out, so I'm not sure. Just give me a minute, because there was a lot of issue with the light just now. And if I'm not able to do it, maybe you can go ahead with your panel discussion.
Or the third talk will start.
Just a minute, if I could go ahead and do it. Otherwise, you can carry over with.
Anjali, it's written bandwidth is low on your screen.
Yeah, but I just can't help it because I'm on my phone network. Is it visible now?
No.
Okay, so please go ahead with your panel discussion, Monica.
We'll let us see. I think we'll start with the third talk, Dr. Divya, because will take a long time, Didi.
Yeah. So go ahead on that. Okay, no worries.
Dr. Purnima, have you contacted Dr. Divya?
Ma'am, I'm calling Dr. Divya.
Okay.
I'll rejoin and I'll see.
Monica ma'am, the phone is no reply. I think busy honge.
Busy, yeah, her call is busy.
Yes.
But panel discussion will be too much to start. Then both the speakers will be left, Yeah, I'm able to call her. Purnima, don't try now.
Ma'am, if Anjali ma'am can send the presentation, then
yeah. You talk to Anjali. You talk to Anjali ma'am. Purnima, please talk.
She could actually share the presentation with any one of us and we can share our screens.
Yes.
Or else if she feels that
just a
probably
minute. I'll just try and do that. Yeah.
Dr. Divya is taking another talk in TOGS, Thane Obsgynae Society. So she will be available after 5:30. Dr. Anjali has left.
So that's another 10 minutes to go.
Another 10 minutes.
Another 10 minutes to go.
So Dr.
Anjali Didi, you are an excellent teacher. So do we really need the slides? Any which way?
Yes. Have you sent the slides to somebody, Anjali Didi? You can send to.
No, not as yet.
You WhatsApp दीदी
We will send you on WhatsApp also.
हम इधर से share कर लेंगे अपने पास से. And we will run the slides and you can speak.
Yeah,
That
yeah,
is the-
just give me a minute.
Just WhatsApp to it.
Are we there?
Yes. We can see your first slide.
Yeah. So this is another learning lesson obstetricians never should give away, right? लड़ते रहो कहीं ना कहीं तो ट्विंस को भी बचा लोगे, माँ को भी बचा लोगे और बच्चे को भी बचा
आपने
लोगे.
नेटवर्क कौन सा लिया? आपने नेटवर्क कौन सा लिया?
Let us see how much I can carry, because I am having a lot of network issues at my home right now. So I'll probably just go ahead and see if I can do justice with the topic. So we were talking about the maternal complications. I'm audible and visible?
You're home now. You're home,
Okay,
you're home,
great.
it's okay.
Great. So I was talking about the postnatal complications, and with that, we have a lot of fetal complications. The first and foremost is definitely the prematurity, which we all are so bothered about. Then there is discordant growth. As Dr. Monica was rightly asking about the vanishing twins, there could be single fetal demise at various gestational age. And probably to get an answer to that as an obstetrician becomes very difficult, because what are you going to counsel the patient? Then many times nowadays we are coming across patients with twins in which you have congenital anomalies. Today morning only I came across a scan report which says that one twin, though unfortunately it is a monozygotic twin, and this report has come from periphery. So I really need to look into the matter and see what answer can I give her. But definitely congenital anomalies in one of the twin can also be one of the concern. Then as we come to third trimester, it is intrauterine growth restriction, then cord entanglement, acardic fetus, vanishing twins, and then which are common complications of monozygotic twins like twin-to-twin transfusion, the TRAP and the TAPs like twin reversed arterial perfusion, and anemia, polycythemia consequences which could be there. When I was reading and preparing for this presentation, I came across one term which mentions that there should be a special care, and the care name is women-centered care. So what exactly this women-centered care means? It is an informed decision. We are coming across so many patients, as Dr. Monica has rightly said, that we need to, and Sunita madam has rightly said that maybe after a while the audit will be on how many twins the ART center is delivering, or how many multiple pregnancies like triplet the ART center is giving as a result. But it has to be an informed decision whether to continue with twins, whether to continue as triplet pregnancy, what exactly the mother and the partner wants. As said, as was rightly told about one patient in the initial introductory presentation, the patient refused to come back to get treated. Madam has given an example. But are we putting a documentation of these things? Because the patient may not come to her and she can directly land up in third trimester with n number of complications. This is a very common scenario in Indian circumstances. So I guess as Dr. Pooja has rightly told us about, one needs to have the end of the act with paper. So informed decision and putting those decisions, the counseling part, into paper and pen is immensely important. I work in a tertiary care center. It's a medical college, and we come across patients who don't even show their papers to us. And then it becomes very difficult for us to find out what is happening with them. Then the women-centered care for multiple pregnancy did mention about general care. I understand that this is very commonly taken care in Western countries. In India, we consider our family members as providing a lot of supports because sometimes it is not true. So we definitely need to tell the patient if there is any issue, they can ask or they can let the person, the obstetrician, know that they need extra help because of whatever the reason the patient can have. So emotional support is significantly important. Screening and diagnostic test, diet and nutritional supplements have to be taken care of when we provide information regarding general care. Lifestyle changes, because we all are obstetricians and we all know that with twins, there comes chances of medical disorders of pregnancy as diabetes, as pregnancy-induced hypertension. So one needs to be aware about what lifestyle changes they can have and with what weight gain, how do they need to proceed in their pregnancy. Then definitely comes the clinical care. Another thing which was interesting was the focus group care. So if you have too many patients carrying twins, maybe you can have a generalized ANC counseling. I'm working in periphery, and this was a new novel way of antenatal counseling, which we are trying in peripheral areas, which says that you should have focus group care for nutritional care. So once we start with this and it comes as a interventional strategy, probably we can have focus group care for pregnancy-induced hypertension or GDM or twins, where all patients are of the same, are riding in the same boat and they realize what we are talking about, and then they can provide support to each other. Family and social support will be a definite part of it. So when we talk about antenatal care and management, the diet and dietary management are definitely of significance. Increased rest at home, early cessation of work, increased iron, vitamins, calcium, and folic acid. I'll not go into the details of it, but yes, we come across a lot of patients who are working still at the end, mainly engineers or techie people. They are doing work from home and then they don't want to take rest. So we definitely need to tell them that they need to take leave, they need to stop their work. And just because they are working online doesn't mean that they should not take care of themselves. More frequent antenatal visits. I have seen patients coming with their online work going on their mobile phone, and then they say, "Madam, please jaldi checkup karke de bhijwa dijiye, meri online meeting hai." So I think this is probably a nuisance of online work culture which we are developing in our society. Yes, we are going back to offline work also, but this online work definitely takes the pleasure out of them coming for antenatal visits. Fetal surveillance with ultrasound, NST, and Doppler studies. Prevention of preterm labor by tocolysis, cervical encerclage, and rest. Steroid administration. Steroid also, one of the part of counseling which I was mentioning, I came across a patient today morning who said that, yes, I have received steroid, but I have just been given 2 injections. Then I had to ask her, how many did you buy? What was given? And I guess this is an interventional change, which I have told my labor room nurses to start from today, that either they need to load the syringe in front of the patient or they need to tell the patient that this much amount we have used and this is one single injection, but it has this much of betamethasone or dexamethasone, and you need to have 2 doses for the same, which will probably make it clear on them that they have received the whole course. Early hospitalization in 3rd trimester and delivery, it should be in a planned way. If we are coming across dichorionic twin, ultrasound at 10 to 14 weeks for viability, chorionicity, and aneuploidy scan. Structural anomaly scan at 20 to 22 weeks, serial fetal growth scans at 24, 28, 32, or then as the case may ask for 2 or 4 weekly scans. 34 to 36 weeks, discussion on mode of delivery and intrapartum care. Elective delivery at 37 or 38 completed weeks. I'm saying elective deliveries because many patients are coming from periphery and it becomes difficult for them, though things are changing, but still many times it becomes difficult for them to reach in time period, and we come across many complications because of that. Postnatal advice and support to increase breastfeeding and contraceptive advices. Monochorionic twins can need to have ultrasound at 10 to 14 weeks for viability, chorionicity, anti-aneuploidy scans. Ultrasound surveillance, definitely as required. at 4 weeks and then at 2 weeks. Structural anomaly scan at 20 to 22 weeks. Fetal growth scans 32 to 34 weeks for decision of mode of delivery and intrapartum care. Elective delivery at 34 to 37 completed weeks, and postnatal advice and support again with breastfeeding and contraceptive on board. The obstetric part of management depends mainly on the presentation, so I'll not go into the detail. We all are aware that there is no obvious contraindication for vaginal delivery or to have a planned cesarean section if the presentation of twins is breech or transfers as first twin. Let me quickly take you through a couple of cases which we came across recently, and probably maybe things can be made easy. We came across a lot of twin pregnancy patients in COVID time, and it was very difficult for us to take care of many of these patients, many of these babies at times because they were preterm and mother was suffering with COVID positive. A lot of issues were there. So if I put up a case in front of you, she's a 24-year-old G2P0L0A1, came at 36 weeks with twin pregnancy, was a non-cardiac patient, which is very rare for them to come as totally unbooked patients after just having one single visit at our place. Because usually cardiac patients, I deal with a lot of them and they listen to whatever you are trying to tell them. She was on anticoagulants, did not have proper antenatal checkups, came in labor, delivered preterm babies. The babies were admitted in NICU. One of the baby the baby died. But the worst part was post-op, the patient had severe post-delivery. The patient had postpartum hemorrhage. Medical management could take care of that, but later on she had vulvovaginal hematoma. A lot of blood transfusions were there, and definitely the patient went with a lot of morbidity on board. Being operated cardiac patients on anticoagulants, probably if she would have come back in proper time, she would have had proper antenatal care, proper counseling, then we could have avoided all these complications on her. The other case is the patient came at 26 weeks with history of cervical encerclage. The patient was a patient on infertility treatment, had a history of failed intrauterine insemination. Cervical encerclage was done around 20 weeks. Came in active labor, cervical stitch had to be removed. Patient refused to undergo even a vaginal examination and see the painful situation. At 20 weeks, after repeated counseling, she denied for a vaginal delivery. She refused to have a vaginal delivery at all. Insisted, as she was a case of infertility, insisted for a cesarean section. Knowing every pros and cons, we had to explain it to her, had to take her for cesarean section. The babies were shifted to an NICU, but all babies were lost in a day or so. I guess all these things happen because repeatedly we don't counsel, and probably we repeatedly don't put it on paper. If we start putting these things on paper, that counsel for this, counsel for that, then they realize the significance of it. The next case is a 40-year-old primary gravida, IVF conception. IVF was done at some other private hospital and was on regular antenatal care. Directly came at 31 weeks with changes in fetal Doppler. She was taken for emergency section, and this patient, I'm aware, we came to know that she is being shifted to our hospital almost 4 weeks prior to we could see her physically. With so much of Doppler changes, she came that 2 out of those 3 died within 5 to 6 hours of post-section, and 1 baby survived after a prolonged NICU stay, but we don't know the later on implications for that baby. My whole insistence is when we are trying to counsel these patients, we need to probably put it in writing. We need to use the paper more often. The points to ponder on this will be whether the patient X had ignorance because both the patient and family didn't realize what they are in. She did not attend her obstetricians or cardiologist for checkups, was on acetylene till the time of delivery, with altered coagulation profile, had to undergo a postpartum hemorrhage and vulval hematoma. The other patient did not seek antenatal care well, had cervical encerclage, which should have been done a bit earlier. She did not agree for any hospital stay probably, which could have had a better outcome. And the third patient, after repeated counseling also, she was referred from some place to our center that probably you don't have to pay this much, your babies will be taken care of as we have Aishman on board. But she did not come to us for almost 3 weeks. So my whole problem is, do we miss on counseling? We counsel them, do we miss on putting them in paper? And what is the implication or what is the message we are putting in the society when we have so many complications? It is very easy to say that obstetricians are at fault, but really only are the obstetricians at fault. After doing so much of fetal medicine work, after doing so much of work for infertility, after a positive pregnancy rate, if we lose babies like this, I think it is a very painful situation for the obstetrician and for the infertility specialist. These are a couple of studies in which we have put up our own papers with high-risk pregnancies having more issues. There is another one with the congenital malformation, which we delivered at our own center. And these are 2 IVF babies which were born last year during Ganpati Utsav. So the name is Riddhi and Siddhi. Now, these are the patients who were treated on infertility. So yes, if the patient realizes what you are doing for them and if they come for regular antenatal checkups, maybe the result could be positive and very happy. But once in a while, we all will agree that we come across patients who don't listen to us and then they come with a lot of issues. And sometimes the issues can't be managed like I had the issue. I'm very sorry for that. But I guess probably I was able to deal with it at the end of it. Thank you so much for patient listening.
Thank you, ma'am. It was a very comprehensive talk, actually with few technical issues. It is a privilege to chair your session actually, because I had worked with you and learned a lot from you. Thank you for everything. There are few take-home messages from your talk: the women-centered care, proper paperwork, a good counseling, defining proper chorionicity, and calling them accordingly 2-weekly and 4-weekly, depending upon the type of chorionic twins they are. So thank you, ma'am. It was a very nice and comprehensive talk.
Thank you so much.
Thank you, Thank you, Dr. Anjali, ma'am, for conveying that message that as howsoever of antenatal surveillance of the multiple fetal gestations that we may learn, but if the patient doesn't turn up, how do we implement all that? So equally important probably is to keep the patient with you throughout the surveillance period. Thank you so much for that beautiful talk.
Thank you, Dr. Varuna.
Thank you, Dr. Anjali. This was, despite the initial hiccups, the talk progressed very beautifully. And I know how much you have, you are lamenting the loss of those triplets. You can sense that pain in your voice. And ready to confess, I've never had, after so many years, almost 18 years of infertility practice, I've never had a triplet pregnancy. I'm proud to say the only time I have a triplet is right now, which is very much in GMC Bhopal now, referred with a cerclage. She's trichorionic triamniotic, and she's an Ayushman patient who refused reduction. So I just hope and pray to God, she's past the target scan period. She's good with the cerclage, cervical length is good. She is on very restricted activity at present, but let us see how things go. So otherwise, it's a strict no to triplets from my side. Thank you so much.
Thank you.
Dr.
So
Puneet.
for our next, yes. So for our next session, session 3. I would like to invite our chairpersons. Our first chairperson is Dr. Mudita Jain ma'am. Ma'am is Professor and Head Obs and Gynae Department in RKDF Medical College, ex-Secretary Bhopal Obs and Gynae Society, past Joint Secretary Bhopal Menopausal Society, faculty for Force PG Update 19 and 15, Executive Member MPOX 2015. She has done Masters in Cosmetic Gynecology, Fellowship in Minimal Access Surgery, FOXI recognized infertility training, ultrasound training she has received, and has published more than 20 papers in various journals. She has attended as faculties in various conferences and is member of various organizations. I welcome you, Dr. Mudita Jain ma'am, on this platform. Next chairperson is Dr. Mansi Jain ma'am. Ma'am is Director, Iris Imaging and Intervention Center, Partner Madhyam CT Scan Center, Consultant Lifeline Hospital. Ma'am is having very good academic records and has been trained in gynae imaging, breast imaging, FMF certified NT-scan, IOTA certified, ICRI certified for fetal radiology fellowship, teaching faculty with ICRI, invited as a speaker in many conferences, Joint Secretary, SFM MP Chapter, Executive Committee Member, RIIA MP Chapter, and ICUMB. Academic Excellence Award she has received. Academic Excellence Award in 2023 she has also received. Organized various conferences and quizzes and has been quiz master in WADA Spire MP State Level Quiz. I welcome you, ma'am, on this platform. Thank you for joining us, Mansi Jain ma'am. So I would like to invite our chairperson for introduction of our next speaker.
Thank you so much, Purnima. Thank you, Monica madam and ISA team for inviting us as chairperson for this session. Now I would like to invite our speaker for the session, Dr. Divya Singh. She's gold medalist in MBBS from IGMC Shimla. She has an MD Radiology from PG Ahmed Chandigarh. She is fellow advanced OBGYN ultrasound from Mediscan Chennai. She has short-term training in medical genetics, Narchi, Mumbai. She has She's a consultant radiologist, prime imaging and perinatal diagnostic Chandigarh, ultrasound trainer and basic training content reviewer, ISOC UK member, ISOC CME task force. She has been awarded by the Ministry of Health, Government of India for providing exemplary services to pregnant women in Chandigarh 2018. She has been awarded prize for best oral paper on ultrasound in endometriosis in Sonocon 2020. She has publications, more than 56 publications and 2 book chapters. Welcome, Dr. Divya, for the session.
Good evening, everyone. Thank you, ma'am, for the kind introduction. And before I begin my presentation, I would like to thank Monica, ma'am, and the entire team organizing the Perfection series for having me again on this esteemed platform. It's my pleasure and privilege to be here. And I congratulate them for organizing one successful webinar after the other. My today's brief is to speak on the guidelines for ultrasound evaluation of twin pregnancy. Now, we all understand from the talks of previous speakers that twin gestation needs extra attention. Twin gestation is on the rise because of advancing maternal age and use of assisted reproductive technology. It's important to be more careful with twins because they have a higher incidence of perinatal morbidity and mortality and a higher incidence of spontaneous and iatrogenic preterm delivery. The complication rate, if we compare, is higher in monochorionic twins, and why that is so, we'll discuss in the course of this presentation. From an ultrasound or a sonologist perspective, scanning 2 babies is challenging because there's a limited space and the babies tend to get in the way. Sometimes you have the head of one person with the legs of the other, or all the legs at one place, and it becomes challenging to see which fetus you are assessing. It's also important to understand certain complications which are specific to twins so that we look actively for them while we are scanning. Now, it's always good to have guidelines from a standardized organization, and ISWOG guidelines on the role of ultrasound in twin pregnancies is one such paper that is worth reading, and you can scan this QR code if you're interested in reading these guidelines, which can act as a foundation before you start scanning twins. Now, before I actually talk about ultrasound in twins, it's important to understand 2 concepts, namely the concept of chorionicity, which means, or rather which refers to the number of placenta, and the concept of zygosity, which refers to the number of zygotes. So chorionicity and zygosity are not interchangeable or synonymous terms. They have different meanings. And by zygosity, if the twins have come from the same zygote, then they are obviously identical. Otherwise, they are not. Now, how does the concept of chorionicity come into play? Now, if the fertilized ovum cleaves at the morula stage, that is between day 1 to 3, we get what are known as dichorionic diamniotic twins. If the cleavage occurs later, say at the blastocyst stage, then there is sharing of placenta between the twins, and that is when we start getting monochorionic diamniotic twins. If the cleavage is further delayed, that is between days 8 to 13 post-fertilization, then there is even greater degree of sharing between the placenta and the vascular anastomosis, and we get what are known as monochorionic monoamniotic twins. And finally, if the cleavage of the fertilized ovum takes place between days 13 to 15, then we get very rarely what we see, conjoined twins. So it's just like life, that if you stay together for a long period of time, you tend to share more things, tend to have more memories in common. If you separate early on, then you tend to have your separate space, separate placenta, and separate life. Now coming to twins, as I said, dizygotic twins are twins which have developed from two different zygotes of fertilized ova. 70% twins are dizygotic, that is, they are non-identical, or what we call fraternal twins in the layman terms. Now the twins which have obviously developed from different zygotes would have different placenta, different amniotic sacs, so they would be dichorionic, diamniotic all the time. However, when we come to monozygotic twins, that is twins which have developed from the same fertilized ovum or the identical twins, they are seen in 30% of twin pregnancies, and their chorionicity can be different. In fact, monozygotic or identical twins can have dichorionic, diamniotic placenta, that is, they can have separate placenta and separate amniotic sacs, though the most common types of monozygotic twins are monochorionic diamniotic. So the most commonly, they do have a single placenta, but with an intertwin membrane and separate amniotic cavities. But do not be surprised if some number of dichorionic diamniotic twins are actually identical. Then there is a smaller number of monochorionic monoamniotic, and very rarely less than 1% of monozygotic twins can be monochorionic monoamniotic but conjoined. Now, how do we assess twin gestation before 10 weeks? Now, before 10 weeks, the first important thing is to diagnose twin gestation, because there is something known as satisfaction of search error. That is, if we see one gestational sac with a fetal pole and a cardiac activity, we are happy that there is a pregnancy, and we don't look very carefully at the entire uterus and end up making a diagnosis of singleton pregnancy. And lo and behold, when the patient is followed up later on, there are twins. So it's important that whenever you are seeing the uterus, you scan the uterus from right to left in the entirety, from top to bottom, and check the gestational sac carefully, and don't just get satisfied if you see one embryo with a fetal pole, because there might be another in one corner which you haven't looked for. So first is diagnosing twin gestation before 10 weeks. Once we have diagnosed it, we look for the viability, and obviously this is done by looking at the cardiac activity. Before 10 weeks, it's not recommended to use Doppler because of the heating effects of Doppler on the developing embryo. So we avoid using color Doppler or pulse Doppler to document cardiac activity before 10 weeks. If we want to measure the heart rate, it should be done with M mode. Then the next important thing is to determine the gestational age, and the best parameter to determine gestational age before 10 weeks is the crown rump length. So as we all understand, crown rump length is preferably measured in a sagittal section, as you see in this image. And this is the crown, that is the part of the head and the rump, the distalmost part in the coccygeal region. And you draw a straight line with preferably the fetus in a horizontal position, if possible, and get the crown rump length to determine the gestational age before 10 weeks. Before 10 weeks, we can also determine chorionicity. Now, how is chorionicity determined? It is determined by the number of gestational sacs. So if you see two separate gestational sacs with two embryos with cardiac activity, the pregnancy is going to be dichorionic. If you see a single gestational sac with two fetal poles and cardiac activity, it is going to be a monochorionic twin pregnancy. In order to determine amnionicity, what we look are at the number of yolk sacs. So obviously we will not be able to see the intertwin membrane very early in pregnancy, say before 8 weeks. And at that time, we can look at the number of yolk sacs. But there is a word of caution here. The number of yolk sacs does not always correspond with the amnionicity. So if you see two yolk sacs, it doesn't always mean that it will be diamniotic. It is always recommended that you document there are two yolk sacs, but to be sure about amnionicity, you scan the patient again after 8 weeks when the intertwin membrane becomes more clear. And do not assign amnionicity just based on the number of yolk sacs before 8 weeks. Now, if you have a look at this 3D rendered image, what you can see here are two yolk sacs. First, we look at the gestational sac. So we see a single gestational sac. So this means this is going to be a monochorionic gestation. We see two yolk sacs. Again, these are fetal poles. This is the typical signet ring appearance of the early pregnancy before 6 weeks. And so since we see two yolk sacs, two fetal poles, we can assume that this would end up being a monochorionic diamniotic pregnancy, but we would confirm it by looking at the intertwin membrane after 8 weeks. Now, this is just a video clip, and we'll try and see if we can assess the chorionicity and amnionicity. Though it has been labeled here, don't believe what is written. Look, and what you see here are two separate gestational sacs. And you can see two fetal poles with cardiac activity, two yolk sacs. So two gestational sacs means dichorionic, and two yolk sacs, two separate fetal. So dichorionic pregnancy is always going to be diamniotic. So that's a no-brainer. This is a dichorionic diamniotic pregnancy. On the other hand, when we have a look at this clip, what do we see? We can only see one gestational sac and two fetal poles. So this is a monochorionic pregnancy. If you look carefully, you can actually appreciate the amnion encasing the two fetuses. So this thin envelope that you see between one and the other fetus is the amnion. So you can actually, just by looking at the amnion here, conclude that this is a monochorionic diamniotic pregnancy. You need not even look at the yolk sacs, though this pregnancy did have two yolk sacs. So as you can see, this is one yolk sac. This is the other yolk sac, so two yolk sacs. But even if I don't look at the yolk sacs, because of the high resolution of the TVS probe, I can see two separate amnions encasing the fetuses. There is one gestational sac, so I'm sure this is monochorionic diamniotic twin gestation. Now coming to assessment of twin gestation between 10 to 14 weeks. Now, we understand that today we live in the era of inversion of pyramid of prenatal care. And according to this concept, most of the screening for complications which occur later on in pregnancy, be it pertaining to the mother or to the baby, is done in the first trimester scan, that is the 11 to 14 weeks scan. And so a lot of things in twin gestation are sorted out at this time of the scan so that we don't have to worry about them later on in pregnancy. The various things that we look for at 10 to 14 weeks, which is more specific to twins, is again, if the patient has not had an early scan, we confirm the presence of twin pregnancy. We confirm that the two fetuses are viable. We assess the gestational age, again, by measuring the crown rump length. But what is more important in twins is to label the twins or to name the twins. And they can be labeled as 1 or 2. We do it A or B. But by convention, it is recommended that in ultrasound, the twin which is closest to the cervix. So as you see here, the sac which is closest to the cervix is labeled as 1 or A, and the one which is away is labeled as B or 2. Now in this case, in this image or the illustration, it's fairly simple. One sac is up and the other is down. But sometimes what happens is that the twins are side by side. So sometimes one sac is down with the fetus to the right. the other sac is up with the fetus to the left. So it's always good that when you are labeling twins, first you document as to how you have labeled them, like whether based on the position up or down or right or left, because this is important, because the next scan, you may not be the one doing the next scan. And even if you are the one who's doing the next scan, you may not remember as to how you had labeled them. So it's always a good practice to document how you have labeled the twins in your report, at least the first report and the 11 to 14 week scan, so that subsequent follow-up is more effective and everybody understands who is A and who is B, and we don't end up mixing the two, because otherwise, if there is some complication later on, it can get very confusing and it can be very misleading. Sometimes in dichorionic twins, since the position of placenta can be different, say for instance, one has an anterior placenta, the other has a posterior placenta, that can also be used as a descriptor. But at times, even in dichorionic twins, the placentae can be fused so that both the fetuses have got an anterior or posterior placenta. And in that case, it will not be very helpful. So please spend some time on labeling and documenting how you have labeled twins, because that makes life very simple later on. As has been explained by ma'am nicely, at 11 to 14 weeks, we have to determine the chorionicity, because this is our last good reliable window of opportunity to confirm chorionicity, which we do by looking for the lambda or the T sign, which I'll explain shortly. And we also assess the amnionicity, because definitely at 10 to 14 weeks, we can see the intertwin membrane very clearly. As we do in singletons, 10 to 14 weeks is the time to screen twins for aneuploidy and structural anomalies. Now, this is what a lambda sign looks like. Before what the sign is, it's important where to look for the sign. So you have to look for these signs at the site where the twin membrane attaches to the placenta. So you have to identify the point. So we will not look for the lambda sign here because there is no placenta here. So where the intertwin membrane is going and attaching to the placenta, that is the area that we look for the lambda or the T sign. So lambda sign, because it resembles the Greek letter lambda, it occurs because of growth of the chorionic tissue into the intertwin membrane. And this is specific for dichorionic twins. So if you see this lambda sign with chorionic tissue growing into the intertwin membrane at 10 to 14 weeks, you are sure this is a dichorionic diamniotic twin pregnancy. On the other hand, we have the T, or it's also termed as the empty delta sign. So again, you will look at the intertwin membrane, but where? At the site where it attaches to the placenta. In this case, there is a posterior placenta, and we can appreciate here that in this case, the chorionic tissue is not growing into the intertwin membrane, and this is what an empty delta or a T sign, if this membrane were to insert directly here, T sign look like. And this is very specific for monochorionic diamniotic twins. Now this is a clip. Let's try to see if we can identify the chorionicity and amnionicity. First, the chorionicity. As I said earlier, we will first look at where the placenta is. So here the placenta is anterior. We will trace the intertwin membrane where it joins the placenta. And where it is joining, you do not see any chorionic tissue growing into the membrane. So this is the T sign. So this is monochorionic diamniotic, because you see the intertwin membrane, monochorionic diamniotic twin gestation. In this case, again, we see two fetuses with cardiac activity. We see a single gestational sac. We see the placenta anteriorly. We are looking for the intertwin membrane, but we cannot appreciate any intertwin membrane between these two fetuses because this is monochorionic, monoamniotic twin gestation. A good point to remember is that if you're not seeing the intertwin membrane in one plane, don't just stop there. Try to change the direction of your probe on the maternal abdomen, angle from one side, angle from the other, because suppose if the twin membrane was in this direction and your ultrasound beam is parallel to it, you may not see the intertwin membrane. So it's the structure on ultrasound is best seen when the ultrasound beam is perpendicular to it. So if you don't see, suppose your probe is in this position, you don't see the intertwin membrane, don't jump to a diagnosis of monoamniotic. Put your probe on one side, the other side, and try to see from different angles that you're not missing out on a thin intertwin membrane of a monochorionic diamniotic twin gestation. Coming to evaluation of twin gestation in the second trimester, again, what we do routinely in the second trimester at 18 to 22 weeks is measuring the biometry, doing a detailed anatomical assessment. However, the assessment of amniotic fluid in twins is done only by deepest vertical pocket, whether it is the second or the third trimester. We come across reports once in a while in which amniotic fluid index has been measured in twins and triplets. That is wrong, that is incorrect, because you cannot divide the maternal abdomen into 4 quadrants as is required to be done for measuring the AFI in twins, because usually the one fetus is on one side of the abdomen, the other is on the other side. So the only reliable method is to measure the deepest vertical pocket. If it is less than 2 centimeters, it is olig. If it is more than 8 or 10 centimeters, it is polyhydramnios. Between 2 to 8 centimeters is the normal. Also, especially in monochorionic twins, it is worthwhile to look at the cord insertion site, or the point where the cord inserts on the placenta at the 18 to 22 week scan, because God forbid if they were to develop complications like twin to twin transfusion later on, these cord insertion sites, their location is important for the operator to understand whether he can perform a fetoscopic laser successfully or not. So it's a good idea to look at cord insertion sites on the placenta in twins. Also, especially in twins conceived by IVF, a higher incidence of anomalies related to cord insertion like velamentous cord insertion or vasa previa have been reported. And so it's worthwhile to have a look at the cord insertion site on the placenta as well. The cervical length in the second trimester, as is recommended for singletons, has to be done by a transvaginal route only. In monochorionic twins, it's also important to measure Dopplers while assessing them every 2 weekly, and especially the middle cerebral artery peak systolic velocity. Why? We'll discuss in the course of this presentation. As has been stated by ma'am earlier, the guidelines suggest that dichorionic twins should be followed up 4 weekly, and monochorionic twins who are more susceptible to complications should be followed up 2 weekly during the entire pregnancy. Now, why is there so much fuss about chorionicity? Why do we need to determine chorionicity? First, because monochorionic twins are at a high risk of complications. Also, how we interpret the combined first trimester screening report is different in monochorionic and dichorionic twins. Remember, there is no role of second trimester biochemical screening in twins. NIPT can be performed, but if you want to do a biochemical screening, then it is only the combined first trimester screening done at 11 to 14 weeks. And the risk for each twin is calculated separately. So it's important that whenever you send the sample in twins for a combined first trimester screen, you mention the chorionicity. Because in dichorionic twins, the risk for trisomies is calculated per fetus and is different for fetus A and fetus B. Whereas in monochorionic twins, where it is assumed that most of them are identical, the risk is the same, or an average risk is calculated for both the fetuses. We understand that twins at a higher risk of anomalies, and especially monochorionic twins at a high risk of certain complications. The risk of spontaneous death before 24 weeks is to the tune of 2.5% in dichorionic and 12% in monochorionic. So it's important to identify chorionicity for this reason. Also, if there is an abnormality in one fetus, then the mode of reduction or a selective fetal reduction is different in dichorionic as compared to monochorionic twins. And if, God forbid, there is a demise of one twin, then its implications are also different in dichorionic as compared to monochorionic. So we can give KCL and do a intracardiac KCL and do a selective fetal reduction easily in dichorionic twins, but that is not an option in monochorionic twins because the vascular supply, or there are placental anastomosis, so the vascular supply between the twins is shared. So what happens to one twin has a bearing on the other twin in case of monochorionic twins. Now, why do monochorionic twins have higher complications is because of this. Now, these are images which have been obtained post-delivery of dichorionic and monochorionic twins by injection of specific dyes. And you can see in dichorionic twins, if you look at the equator or the region of the intertwin membrane between the two placentae, you can see that there is no communication between the vasculature of twin B and twin A. So this is how the placenta is different in dichorionic twins. Whereas in monochorionic twins, if you see here, this is the part which was supplying the first twin, and this is the part which was supplying the second twin. These images have been obtained by injecting the dyes through their umbilical cords. And you can see here that there are actually vascular anastomoses. So the vessels coming from the placenta of twin A are communicating with the vessels from twin B. And so because of these vascular anastomosis in monochorionic twins, there are higher rate of complications. And why? If something happens to this twin, it has a bearing on the other twin. Now, complications which are unique to monochorionic twins include selective fetal growth restriction when one twin is smaller than the other, twin-to-twin transfusion syndrome, twin anemia polycythemia sequence, and twin reversed arterial perfusion sequence. So what these imply is that in selective fetal growth restriction, you will see a discordance or a difference in growth of fetuses. In twin-to-twin transfusion syndrome, what you see is a discordance or difference in the amount of amniotic fluid. In twin anemia polycythemia sequence, there will be a difference in the middle cerebral artery peak systolic velocity, because one twin will be anemic and would have a high peak systolic velocity, whereas the other would be polycythemic with a lower peak systolic velocity. And in twin reversed arterial perfusion sequence, there will be a discordance in anatomy. So one twin will have a normal anatomy while the other twin will be very dysmorphic, as we will see. Now, selective fetal growth restriction, why does it occur? Because of unequal sharing of the placenta. So one fetus takes a bigger share of the placenta and the smaller one has a smaller share of the placenta. So if you have a smaller placenta, you are going to be small. When do you start suspecting selective fetal growth restriction? When the estimated fetal weight is less than 10 centile in one fetus, and the difference in weight or the discordance in weight is 20% or more. How do we calculate this discordance in the estimated fetal weight? We subtract the weight of the smaller fetus from the larger fetus and divide it by the weight of the larger fetus, multiply it by 100 to get a percentage. And if this percentage is 20% or more, it is suggestive of selective fetal growth restriction. Now, when there is growth restriction, we are obliged to do Dopplers. So based on the umbilical artery Doppler waveform, there are various types of selective fetal growth restriction because they have different outcomes. In type 1 selective fetal growth restriction in monochorionic twins, as you can see here, there is increased pulsatility index, but there is forward diastolic flow. And obviously, since there is forward diastolic flow, they have a good survival rate to the tune of 90%. In type 2 selective fetal growth restriction, there's a 30% risk of intrauterine fetal demise and 15% risk of neurological morbidity. What we see here is absence of diastolic flow, as you can appreciate in this Doppler image of the umbilical artery. In type 3 selective fetal growth restriction, what you see is that there is intermittent diastolic reversal. As you can see here, you see diastolic reversal here, but then there are times when the diastolic flow is present. So in twins, monochorionic twins with selective fetal growth restriction, if there is intermittent diastolic flow reversal, that is also not a good sign because it has a 10 to 20% risk of sudden intrauterine demise and a high risk of neurological morbidity. It's a good practice to look for these Doppler waveforms close to the placenta, especially this type 3 waveform. It is actually not picked up that well in the free loop of the cord. It's actually picked up closer to the cord insertion site on the placenta, because this is because of vascular anastomosis. So sometimes the flow in the vascular anastomosis is going in one direction, at the other times it's going in another. So this is best picked up close to the placenta. So that is where you need to perform the Doppler in case of selective fetal growth restriction to pick up these abnormal waveforms. Now coming to twin-to-twin transfusion syndrome. In this case, there will be discordance in the amount of amniotic fluid. Why does twin-to-twin transfusion syndrome occur? This occurs because of hemodynamic imbalances in the two fetuses because of presence of unidirectional arteriovenous anastomosis. So there are arteriovenous anastomosis because of which there is more fluid in one twin, and which is known as the recipient, and there is less fluid in the other twin, or olighydramnios, in the donor twin. This, again, we will diagnose it by measuring the deepest vertical pool. So before 18 weeks, if the recipient has got more than 8 centimeters deepest pool, then it is taken as polyhydramnios, and donor should have amniotic fluid deepest vertical pool of less than 2 centimeters. After 20 weeks, this cutoff can be more than 10 centimeters. If TTTS is left untreated, it has been found to have a high mortality and morbidity in the surviving twins. Because remember, when there is demise of one twin due to TTTS, it has a bearing on the other twin. And the treatment of choice, as I said earlier, is fetoscopic laser ablation. What they do here is that with the help of laser, these arteriovenous anastomosis are ablated. And as a result, this hemodynamic imbalance is corrected. Now, this is a clip. I would like you to have a look at this clip of a monochorionic twin gestation. You can appreciate here that there is one fetus on top left corner of the screen and the other fetus here in the bottom. Even if you don't measure, you can appreciate that this fetus has a large amount of fluid. Obviously, the deepest vertical pool will be more than 10, whereas the fetus which you saw on top, it is defying all rules of gravity. Why should a fetus be stuck like that on the top? This is because there is hardly any fluid around this fetus. The intertwin membrane is stuck to it. And this is what we call as the poly-olig or the olig-poly sequence, which is typical of TTTS. What is interesting is that here the recipient twin, that is the twin who has polyhydramnios, also has some degree of ascites. So if you see here, there is some degree of ascites in the recipient twin. So it's actually showing features of hydrops with skin thickening and ascites. Now, based on the various manifestations, TTTS is graded into 5 stages by Quintero staging. Now, if there is just discordance in the amount of liquor, that is just oligopoly sequence, then it is stage 1. However, if besides the oligopoly sequence, you see empty fetal bladder in the donor twin, that is the twin with olig, you see empty fetal bladder, you have to wait. You have to wait for the bladder for at least 60 minutes. And if you don't see it, then you label it as stage 2 TTTS. So bladder discordance is stage 2. In stage 3, there would be abnormalities in the Doppler. There can be absent or reversed end diastolic flow in the umbilical artery, or there can be reversal of A wave in the ductus venosus, or a pulsatile waveform. So whenever you are seeing a patient with TTTS, you have to look at the amniotic fluid, the bladder, the Dopplers, and then look for signs of fetal hydrops. Because if the recipient fetus has got fetal hydrops, then it becomes stage 4 TTTS. And if there is demise of one or both the twins, then it would be stage 5 TTTS. So this is the staging system for twin-to-twin transfusion syndrome. The importance of this staging system is that stage 1 TTTS, as of now, usually doesn't merit upfront fetoscopic laser. These twins can be monitored more frequently, and higher stages of TTTS obviously would require urgent intervention. Of course, in our patient, since there was hydrops in one fetus, the recipient, this was a case of stage 4 TTTS. Coming to twin anemia polycythemia sequence. So as the name suggests, one twin will be anemic, the other would be polycythemic. And why this condition occurs? This again occurs due to arteriovenous anastomosis in the placenta, but these anastomosis are very minuscule. They are less than 1 millimeters, very small in size. And so they don't result in TTTS, but they result in twin anemia polycythemia sequence. Now, twin anemia polycythemia sequence can occur spontaneously. It's not a very common complication, but it can occur on its own. But it can also occur post-laser. So if an individual has done laser for TTTS, so there are some microscopic anastomosis which may not be seen on fetoscopy. And if they persist, they can result in twin anemia polycythemia sequence. So post-laser monochorionic twins are always monitored for this complication. Now, how do we diagnose TAPS or twin anemia polycythemia sequence? Anemia in one twin is defined as when the middle cerebral artery peak systolic velocity is more than 1.5 moms or multiple of median. Whereas polycythemia is when the peak systolic velocity is less than 1 mom. Also, in case of frank twin anemia polycythemia sequence, there is difference in the echogenicity of the placentae, as you see here. So the twin, which is a recipient, can have an echolucent placenta, whereas the donor twin can have an echogenic placenta. When these twins are delivered, or if you do a cord blood sampling, if there's a difference in hemoglobin of 8 grams per deciliter or more in the twins, then it is labeled as twin anemia polycythemia sequence. So this is an image just to show the middle cerebral artery Doppler and the difference. So in the twin who is anemic, there would be high peak systolic velocity. This has been recorded at around 18 weeks of gestation. This was a case with spontaneous twin anemia polycythemia sequence. There was no laser done here, but you can see there was high peak systolic velocity in one and low peak systolic velocity, which was less than 1 mom in the other twin. Another interesting thing which has been observed in the recipient twin, that is the polycythemic twin, is this presence of a dark looking liver with echogenicities, which is also called as the starry sky appearance of liver. So besides looking at middle cerebral artery peak systolic velocity, it's also a good idea to look at the echogenicity of the placentae as well as at the echogenicity of the liver in these cases. Last, we have twin reversed arterial perfusion, or the TRAP sequence, which is a rare complication seen in 1 in 35,000 pregnancies. In this, as I said earlier, there is discordance in the anatomy. So one twin is perfectly normal, as you can see in this illustration, while the other twin will be very dysmorphic in that it will be an acardiac mass. It will not have a heart of its own. Rather, its blood supply would be coming through the umbilical cord of the other twin. So the upper half of the body, so you will see an amorphic kind of a mass in a twin pregnancy, where you will not see the upper half of the body of one baby and will not even see the heart of that baby, because the blood supply would be coming from the co-twin. This blood supply is through presence of arterioarterial anastomosis between the two twins. The problem in this case is that because the healthy twin is supplying this acardiac twin, there can be high output failure because of hyperdynamic circulation in this normal twin, who is known as the pump twin, because he's pumping blood to the co-twin. So this fetus can go into cardiac failure. So if you see an acardiac mass or a TRAP sequence, it's important to look for cardiac strain in the pump twin, because if you see any features of cardiomegaly or abnormality on fetal echocardiography, or you see a sudden increase in growth of the acardiac twin, or there is increase in amniotic fluid, you suspect that this twin is going into failure. Nowadays, there is treatment for TRAP in the form of radiofrequency ablation of this acardiac twin. So remember, we cannot use KCL here. There is no heart. And as such, use of intracardiac KCL is not possible in monochorionic twins, because if you were to give KCL to one twin through the anastomosis, it can go to the other twin and affect the other twin. Also, if there is demise of one twin, what happens is that there is loss of blood from the healthy twin into the twin which has passed away. And as a result, the healthy twin, because it bleeds into the dead twin, has hypovolemia, and that is why a lot of neurological complications occur when there is demise of one twin in monochorionic pregnancy. So in these cases, in trap cases, or if we are late or we are able, if we are to reduce a monochorionic twin, we prefer techniques like radiofrequency ablation, which have their effect only on the affected twin and ablate the vascular supply to the normal twin. Now, this is an example to show you the twin reversed arterial perfusion sequence, where you can appreciate this is a normal baby at around 19 weeks of gestation. But if you see next to the head of this baby, you see this dysmorphic kind of a fetus, which doesn't have a heart. This is the umbilical cord, and it was receiving blood from this normal fetus through this umbilical cord. So the upper half of the body typically of these acardiac or trapped fetuses is not seen, as you can appreciate again in this clip. So this is the trap mass and the normal fetus next to it. This type of appearance is seen, it can be seen in both monochorionic as diamniotic as well as monochorionic, monoamniotic twin pregnancies. Now, this is just to show you the blood supply to this trap mass, which was coming from the normal fetus. So it is receiving blood supply, but not of its own. Now, let's revise what we learned earlier. Now, this is an early pregnancy at 7 weeks. So can we identify chorionicity here? Yes, we look at the gestational sac. There is a single gestational sac. So we know this is a monochorionic twin pregnancy. But we also see 2 yolk sacs. So 2 yolk sacs, it could be a monochorionic diamniotic, but we will not be sure. We will be sure only if we see 2 amnions or if we see the intertwin membrane. Actually, this is a case taken from literature showing you the exception. This case turned out to be a monochorionic, monoamniotic twin at 10 weeks. So despite the presence of 2 yolk sacs, when the case was followed up, there was no intertwin membrane. And so just don't rely on the number of yolk sacs to predict amnionicity follow-up. There is no hurry in predicting amnionicity. We can wait. Chorionicity, we've already done. Now, this is another case. If we look at chorionicity and amnionicity, well, there's a single sac here. So this is going to be monochorionic. Both the babies are looking at each other. And if you have an eagle eye, you may have noticed that actually both these fetuses are joined to each other. They have a strange kind of position. So they are actually a case of conjoined twins, and conjoined twins are always monochorionic, monoamniotic. There can be various types of conjoined twins depending on where the union is happening, whether it's happening at the level of the chest, the abdomen, the ischial region, the head, etc. Now, this is the head of a twin baby, of twin B at 28 weeks. Now, if you see this image, this is an image measured, taken to measure the biparietal diameter and head circumference. But one look at the image and you understand both in the transcerebellar and in the transventricular plane that there seems to be a lot of black fluid here in the brain. So actually this brain has undergone liquefaction. So why has this happened? Because this was a case of monochorionic diamniotic twin pregnancy. Twin A had succumbed, twin A had died because it was having severe selective fetal growth restriction and abnormal Dopplers, and it had been left as such. And usually it takes around 4 to 6 weeks for these neurological sequelae to appear in the co-twin. And what we saw at this point of time was liquefaction of the brain. As I said earlier, why this occurs? Because this twin bleeds into the dead twin, and as a result, it has hypovolemia, and as a consequence of which ischemic changes are seen in the brain, as are seen in this baby. I also stressed on the importance of looking at cord insertion in the placenta. Why? Because once in a while, you might come across a case of abnormal cord insertion. So this was a fetus, a dichorionic diamniotic twin pregnancy conceived by IVF. And we could see the umbilical cord vessels inserting into the, first traversing into the membrane and then reaching into the placenta. But also, what was interesting was that these vessels which were traversing through the membrane were very close to the cervical canal. So they were just at a distance of 0.8 centimeters from the internal os. So this was not only a case of velamentous cord insertion, but velamentous cord insertion with vasa previa in fetus A. So to conclude, please remember that there is no report, a report which just says twin gestation is useless. It has to specify the chorionicity and, if possible, amnionicity. Chorionicity is best determined before 14 weeks by looking at the site where the membrane inserts on the placenta. Zygosity and chorionicity are different concepts. All monozygotic twins are not monochorionic. Some can be dichorionic too. And monochorionic twins are important to identify because they have a high rate of complications, which are very specific to them because of placental anastomosis and unequal placental sharing. And it's recommended that unless you are very skilled at doing a assessment of a singleton, you do not venture into scanning twins, because ultrasound assessment of twins is a bit more complicated and is best performed by an experienced operator. Thank you.
Dr. Divya?
Yes, ma'am.
In the last slide,
yes, ma'am.
All monochorionic twins are not monozygotic. I think all monochorionic twins are monozygotic, no?
Just a minute, ma'am.
I think the last slide, third line or fourth line.
Oh, I'm sorry, ma'am. What I meant was all dichorionic twins are not monozygotic.
Thank God.
Yeah, I'm sorry. I think I didn't say that. What I said was that
You said the right thing, but I read the, yeah.
I'm sorry. I'm very, very sorry for that.
No,
My
no, it's
apologies.
okay. It's okay. At least I tested my knowledge.
Yes,
through
yes, ma'am. You are bang on. You are right. Sorry for the typing error. All dichorionic twins are not monozygotic. That's what.
I have a few questions.
Yes.
Hi, Divya. It was very, very well covered.
Thank you.
And I would just like to ask whether there is any role of intrauterine transfusion in TAPS, that is twin arterial, twin anemia polycythemia.
Yes.
Yeah.
Initially, ma'am, the role of transfusion comes only when we see hydrops. So if there's just anemia polycythemia sequence, all that we do is close monitoring. If we start seeing features of hydrops, that is when we usually go for transfusion. Because
is there any study showing, because I have
there are some
not
cases which
come across.
resolve spontaneously. There are some cases which resolve spontaneously. So every intervention procedure has its, complications. So we don't want to rush in. Sometimes masterly inactivity is a good idea. So we put them on close surveillance. And if we start seeing features of failure or something, that is when we intervene, because sometimes TAPS may resolve spontaneously.
Yeah, because the sensitivity of even MCA monitoring in case of twins is not very good. Means they might look.
It is recommended. The guidelines.
Yeah, it is recommended, but in twins means you can't intervene just on the basis of MCA PST being very high or MCA PST being very
No, only when you start seeing features of hydrops.
Features of yeah. And what do you say on co-twin demise in case of DCDA twins? Is it scary or just?
No, nothing to worry, because there are no placental anastomoses, so nothing to worry.
And is there any risk of DIC to the mother?
No.
No. And what happens if there is co-twin demise in case of MCDA twins? Is it scary or?
Nothing happens to the mother, but unfortunately, it's not good news for the co-twin, that is the twin which is alive, because the twin which is alive, its heart is beating. So it will lose blood into the twin which has passed away. And as a result, it is prone to develop ischemic complications, yes, neurological complications, which will not manifest immediately, may take 4 to 6 weeks. So it's recommended that either you do a good neurosonogram at 4 to 6 weeks, or if that is not possible, then do a fetal MRI.
And just last question, if the combined test shows high risk in case of the dichorionic diamniotic, so should we advise double amnio or amnio of the fetus with high risk?
That is your call. Actually, if but that risk is, see, in dichorionic, you would have separate risks.
Separate risk, that's what I'm saying.
So each of them has a risk, or only one?
One of the twin has a high risk.
Yes.
And
so
the other twin has.
Then you can always sample the other twin, because dichorionic twins usually tend to have different genetic makeup. But before you sample, you must do an early anomaly scan to be sure that the one which you're not going to sample doesn't show any obvious abnormality. Right.
Yeah, should we counsel, right, even the dichorionic twins can be monozygotic, so we are not very sure that they might have a similar genetic makeup.
Exactly. So that has to be done. You have to tell that very rarely they can have, the same kind of genetic makeup. So, I mean, it's how you go around. Mostly dichorionic twins, they have different genetic makeup, right? So even if they have the same genetic makeup, you sample one, you would automatically be sampling the other, right? So it doesn't matter. The main question is whether you sample the one which is low risk or not. So
Sample the
usually-
right one, which is
Yeah,
fetus A and fetus B. Labeling is important.
yeah.
We had we had a talk by Dr. Chinmay last week.
Yeah, ma'am.
Yeah, so in that Dr. Chinmay, Dr. Divya, she discussed the same case and she said to be on the safer side that,
Double amnio.
their thing that dichorionic is from a monozygotic splitting. She said you sample both the sex to be on the safer side.
Yeah, ma'am. That's everyone has a different say on this.
Exactly.
So,
There is no guideline.
No
So
guidelines, no
you have
validated
to,
studies.
see how your patient is. So you offer both the options. You tell them what are the pros and cons and let them decide that.
Cafeteria approach. You give them everything, let them decide.
Perfect. Yeah.
Dr. Divya, one of the slides in which you showed that the fluid in the brain of the fetus, that was the dead co-twin or it was the live
No,
twin?
ma'am. Dead is dead. No, ma'am. That is not dead. That is the live twin.
And
Because
it had fluid. Why did it have fluid?
It had fluid because what happened was it bled into the dead twin. Dead twin, there is no point of showing the brain of dead twin because dead is dead anyway. The live twin, because it bled into the dead twin, there was ischemia. So there was less blood supply to the brain. So as a result, ischemia, and following that, there was what we call leukomalacia or infarction.
Porencephalic ban jayega later on.
And another doubt I just had after your talk was when there is a single co-twin demise in monochorionic pregnancy, it is the live fetus which exsanguinates into the dead fetus.
Yes, ma'am. Because it's
then why does neurological sequelae develop in the live fetus?
Because it's losing blood, ma'am. So there is hypovolemia, ischemia.
It's all hypoxia.
You are bleeding. You are losing blood. So brain requires a lot of blood.
Actually, hypoperfusion injury.
When we were doing post-graduation, we felt there were some toxins going from the dead baby. It's not
No. It's the other way around, ma'am. It's losing blood.
All because of hypoxia.
Ischemia, hypoxia.
And basically hypoperfusion injury to all organs, not only brains, even kidneys, even liver, everything shuts down.
Yeah, but brain is the one which
which we can detect
and
easily.
Literature says that by the time you detect it, already it is too late.
Yes, ma'am. 4 to 6 weeks.
Yeah.
So in monochorionic twins, it's very difficult to save the monochorionic twins. It's very difficult to save the other if one dies.
Yes, ma'am. Usually the outcome is distal.
Is very
Even if you
So before the baby dies, we have to intervene and coagulate the cord of the twin who is dying so that there is disconnection between the two twins and we can save
Exactly. If you can't treat the underlying condition, say if you can't treat the TTTS and you feel, then it's sometimes you have to give the option of sacrificing one twin by doing an RFA or a laser to save the healthy twin.
Okay.
So when you do this fetoscopic laser coagulation or RFA, why don't you transect the cord at the same time? People say that some vascular anastomosis might remain. So
And cord transection is done only if there is monochorionic, monoamniotic. Because अगर बीच में membrane है तो cord का कोई effect नहीं होगा मैम. Supposing there are monochorionic, monoamniotic twins, क्योंकि उनमें cord entangle रहती है most of the time. That is when if you do a laser or a RFA ablation of one twin, you do a cord transection as well. But in diamniotic twins, you don't need to do a cord transection because दोनों का cord तो अलग-अलग है मैम. It is just these anastomosis which are the problem, not the cord per se.
So in diamniotic, dichorionic twins, if one fetus dies, the other is not at any risk, any greater risk than
No, ma'am.
because of
No,
the
ma'am.
demise.
No, ma'am. It's just
Absolutely,
like how we do triplet reduction. Like triplets also we reduce one, so there is no
But
risk.
if it happens at 26 weeks, I've had a patient.
It usually, ma'am, even we've had patients, but fortunately we've not had any complications.
So the
Just
other
now, I
twin
think Dr.
delivers at
Divya-
term.
Yes,
Yeah, Dr. Divya or Dr. Pooja just now talked that you can be as comfortable with DCDA like a singleton.
Yes, ma'am.
Yeah.
You know, DCDA.
That is why chorionicity, establishing chorionicity is very important early on.
Yes. So thankfully we have lots of DCDAs.
Yes, ma'am.
Lots and lots of DCDAs.
Yes,
So that is one thing we ART people are very happy all the time.
Yes, ma'am.
I've been very lucky with all my twins have been DCDA And all of them have got good outcomes after 36 weeks delivered.
That's
so I'm
true.
really, really lucky in that sense.
Good antenatal care, Monica.
Yes.
Thank you so much. Thank you so much, Dr. Divya and Mansi. Thanks for the great interaction.
Thank you.
Purnima, can we start the panel?
And Dr. Archana Mishra ma'am has joined us. Dr.
Yeah,
Archana.
please, we must welcome Dr. Archana, who took all the trouble of joining us. She must have rushed from office right now. So can you introduce her, Dr. Purnima? Dr. Vishal, can we have Archana ma'am CV again? Just we'll give 1 minute in welcoming her.
We may continue. No need to be formal. Let us continue. It's a very good deliberation.
It is very important that you are, welcomed and acknowledged, because I know with so much of difficulty and so much of, battle with time, you manage all these extracurriculars.
No, when I listen to such deliberations, I become a clinician, at least in my thoughts. I'm listening.
Go ahead.
Ma'am is a state program officer, Maternal Health National Health Mission, Government of Madhya Pradesh. Ma'am is an alumna of GMC Bhopal and has done undergraduation and post-graduation with Laurels. And she subsequently joined State Health Services and is conducting actively and dedicatedly various health activities across the state. We applaud all your hard work and dedication, ma'am. Thank you so much for joining us today.
And it is because of Archana Didi that we are able to so comfortably do all the activities in DOGS and personally in our nursing homes. Any problem, we can approach her, we can talk to her, and she always has a solution for our problem.
Just one point, Monica, I would like to share with everyone that Monica is the pillar behind the Ayushman Bharat, this infertility thing we have introduced in Madhya Pradesh. I think Madhya Pradesh is the only state who is supporting patients with infertility problem for IUI and IVF. And thanks to, I think Randhir is also there. He was more active at that time. So I must thank both of you. So let us
He's always so active. His only regret in life is only one, that why didn't he do MD Gynae? I think, acha hua, otherwise 2 gynecologists in one house, we would have had a lot of competition,
And one thing I would confess also, that this CV is made by Monica. My CV.
Thank you so much.
Thank you so much.
Thank you so much for joining, Archana Didi.
Okay, continue.
So, let us move to the panel, Dr. Purnima.
Yes, panel discussion, ma'am. For our panel discussion, I would first like to introduce our moderators.
First, tell us the topic of the panel, Purnima. Please tell us the topic of the panel.
Yes, the topic is clinical challenges in screening and management of multiple pregnancy. Our first moderator is, next slide please, Dr. Monica Singh, ma'am. Of course, ma'am doesn't need any introduction. And as we all know, that ma'am is very keen academician. And this is our Perfection series. Ma'am is co-convener and ma'am is actively conducting this is our Perfection series. And we all are blessed to have ma'am with us on this platform. And the sole vision of ma'am for this series and Symbiosis series is to provide the best of the knowledge in the field to the obstetrician, so that we can take care of the patient with our best knowledge. And ma'am is also founder and convener of Foxy Symbiosis webinar series, which has recently been started. Ma'am is participant of multicentric Indian RCTs Mother Study, which won the Best Publication Award, and also Antioxidants in Male Infertility published in TCP. So we are very thankful to Monica ma'am, you for this Our Perfection series and Foxy Symbiosis series.
Thank you, Purnima. Thank you so much.
And our next moderator is Dr. Manupriya Madhavan. She's consultant fetal medicine, Apollo Sage Hospital, Bhopal, an alumna of SGPGMS Lucknow. She has been trained at London School of Ultrasound, Fetal Medicine Foundation UK certified, special interest in fetal echo and fetal neurosonogram, and and member of various societies, and has published various journals. Welcome, Dr. Manupriya. Next slide, please. Our first panelist is Dr. Amarjeet Manghani. Ma'am is Managing Director, Govind Fertility Center in Govind Netralaya. And she is Director, NGO Jyoti Cultural and Social Welfare Society, Sihor, visiting consultant at Indian Institute of Science and Research, Bhopal, and she has done fellowship in ART and is trained sonography, Baroda. Welcome you, ma'am. Next slide, please. Next panelist is Dr. Geeta K. Rai, ma'am. Ma'am is MBBS Gold Medalist, Associate Professor, Department of Obs and Gynae, School of Medical Sciences and Research, Sharda University, Greater Noida, UP, India. She has won so many awards and has published various papers in journals. We welcome you, Dr. Geeta K. Rai, ma'am. Next panelist. It is my honor to introduce Dr. Manisha Khare, ma'am. Ma'am is President of Bhopal Obs and Gynae Society from 19 to 20, Senior Vice President of BOGS for 6 years, Speaker and Chairperson in CMEs, Life Member of Indian Menopausal Society, Vice President MPOX, and is having very excellent academic records and National Award for President Best Branch, PM Surakshit Matrat Abhiyan, visiting consultant for various MP government departments. Dr. Manisha Khare, ma'am, we welcome you. Thank you for joining us, ma'am. Next panelist is Dr. Pallavi Agrawal, ma'am. Monica, ma'am is there. Ma'am, message that ma'am will not be able to join. Dr. Pallavi Agrawal, ma'am. I think ma'am hasn't joined us today. Next slide, please. Next panelist is Dr. Sapna Bajaj Jain, ma'am. Ma'am is an alumna of St. James Medical College, Director of Obs and Gynae Services, Sagar Multi-Speciality, Bhopal, ex-professor of Obs and Gynae. Also has worked in CHL Apollo, Indore, Apollo Sage Bhopal and Birla Hospital. And she is author of the various chapters in the books and has received various awards. Thank you for joining us, ma'am, as panelist. Next panelist is Dr. Sonal Jain. She has done fellowship in reproductive medicine, Associate Professor, Chirayu Medical College, and won award for best poster at AICOG and member of various organizations. Thank you, Dr. Sonal Jain, ma'am, for joining us. Next is Dr. Vandana Agrawal, ma'am. Ma'am is Associate Professor in Obs Gynae Department in RKDF Medical College, Consultant Gynec and Laparoscopy Surgeon of Multi-Specialty Center of BFH, FMFI certified. She has done fellowship in minimal access surgery and has published various papers and presented papers and posters also. Welcome you, Dr. Vandana Agrawal, ma'am. Next is Dr. Virul Srivastav, ma'am. Ma'am is Consultant Gynec and Fertility Specialist at Indra IVF Bhopal, past Secretary of Deoli Savangi Obs and Gynae Society. She has won so many awards and has done so many academic training. Yes. Dr. Virul, ma'am, we welcome you. Thank you for joining us. So I would like to hand over the session to our moderators.
Thank you, Dr. Purnima.
Thank you so much, Purnima. And I think I'll start sharing my slides now. The panelists have revised everything in so many lectures. And so whenever we want to stop the panel, they can tell me whenever dinner time is ready and they want to stop, we can stop the panel. There is no hard and fast rule. It is just repetition. And I hope all of you will do a good job and all of you will enjoy. So we have clinical challenges in the screening and management of multiple pregnancies, which we are going to discuss in the next 30 to 40 minutes. We have been introduced to our esteemed panelists. So my question to Dr. Amarjeet is that, Dr. Amarjeet, why are we all so concerned about multifetal pregnancy? Can you listen to me? All of you can hear me? Yeah. So why are we so concerned about multifetal gestation and about its hazards and its complications? Dr. Amarjeet.
First of all, thank you to Monica ma'am and all the Perfection Series for conducting and giving me a chance. Thank you very much, ma'am.
One second, Amarjeet. I would request all panelists to please, participants to please mute themselves and let only the speaker speak so that we have silence. Okay, please continue, Amarjeet.
Thank you to you, ma'am, for making this webinar Perfection Series and conducting it so nicely and giving so much of information to all of us. And recent and updated. Thank you very much for this. And when we come to the question, I think the incidence of multiple pregnancy is rising because there is delayed childbirth and advanced maternal age at conception. And we see that there is widespread use of ART techniques, and due to ovulation induction and all, we do get twin pregnancy and triplets. Now, it is of concern to us because there are a lot of twin pregnancy or multiple pregnancies always risked as a high risk pregnancy, because we see a lot of perinatal and neonatal morbidity and mortality as compared to singleton pregnancies. And it is seen that there are more cases of preterm in prior births compared to 37 weeks of gestation if they occur in up to 60% cases. And I think main reason, and if we go to the facts and findings, there are more chances that stillbirths are also high, because as compared to singleton pregnancies, they are more. In singleton pregnancies, the chances are 5 per 1,000, and in twins it is up to 12, and in multiple triplets and higher order, it is still higher, 31% or more.
Thank you, Dr. Amarjit. Thank you for the answers. So let us move to the next question. You have been very correct, because we are concerned because we have lots of preterms and lots of stillbirths which can be added. Just now, Dr. Anjali Kanhare told us about the triplet cases where all the 3 babies were lost because of prematurity. Okay, so moving to the question number 2. How do we date a twin pregnancy? See, labeling is different, assessing the chorionicity is different, but dating a twin pregnancy is different. If you're doing an ultrasound yourself, you date it yourself. And if you're seeing an ultrasound report given by a sonologist, you should know how to read that date and assign the EDD to twins. Remember, all twin pregnancy have to have a common EDD. You cannot tell a gravid mother or an expectant lady with carrying twins that this baby will deliver on 15 January and the other baby will deliver on 7th February. You have to give a common EDD. So kindly give me, Dr. Geeta, the guidelines for dating a twin pregnancy.
Good evening, everyone, and thank you so much for having me, ma'am. So we can have twin pregnancy because of 2 reasons. Either it can be a spontaneous conception or it can be a result of IVF conception. So as per the guidelines given by International Society for Ultrasound and Obs and Gynae, so if the pregnancy is a result of IVF conception, so we know the date of oocyte retrieval, so we can calculate the EDD from that date. And if it is a spontaneous conception, so from it that the time that we utilize for the NT-NB scan, that is from 11 to 13 plus 6 weeks. So using the CRL of the larger twin, we can date the pregnancy. And if the patient has crossed that period and has come after 14 weeks of gestation, then using the head circumference of the larger twin, we can date that pregnancy.
So can you tell me, Dr. Geeta, why are we using the larger CRL and larger HC? Why don't we use the smaller one? Everybody has got a smaller baby also. Can you give the reason?
Yeah, because we are not sure about the measurements that are being taken. So ideally it has to be an average, but because we are given 2 babies with their own parameters, so probably we are using, if I'm not wrong, you may correct me, ma'am.
That's not correct. Can any of the panelists tell me why do we use always the larger CRL and the larger HC? Why don't we use the smaller one, smaller measurement? Any panelists? This question is.
Ma'am, because it is rare to have a growth restriction so early.
It is, in fact, it's the other way around. The smaller baby has some early growth restriction which is already manifested, but it is very rare that there will be a macro
large for yes, ma'am.
And for large NT, if we are getting a large NT.
We are not talking about NT, we are talking about CRL and HC, dating. So whenever we date, it is naturally the larger CRL is easier to measure, no doubt. But according to guidelines, we use the larger one because it is very rare that macrosomia will have its onset so early on in gestation, whereas early onset, very early onset fetal growth restriction can manifest as a smaller baby. Okay, so that is why we use the larger one. Okay, so coming to the next. This is what I told you, gestational age in spontaneous conceptions, you base it on the CRL of the larger fetus. The larger the fetus you measure, the smaller will be the window of error. And in IVF conceptions, you measure according to the date of embryo transfer, plus 2 weeks. So suppose the embryo is 3 days old, that is day 3 transfer, that period will be calculated as 2 weeks, 3 days at the time of positive pregnancy test. So from that, every ART practitioner can calculate the expected date of delivery. And every patient carrying multiple gestation has only one expected date of delivery, never two. So Dr. Manisha Madam, how do we determine chorionicity in a twin pregnancy? And is chorionicity more important or amnionicity more important?
So Dr. Divya, she has told us, she was my trainer when I did ESOP training. She's a very good teacher. So chorionicity, before 10 weeks can be determined by number of gestational sacs, as she's just said, and amnionicity by number of yolk sacs. Although it may not be necessary that these yolk sacs can always be the correct method. And secondly, after 10 weeks, when you can see the amniotic membranes, then you can diagnose clearly. See, when it is a dichorionic pregnancy, in that case, the amniotic membrane will be thick because of the 2 chorions and 2 amnions, which are fused together, and it forms in the shape of a lambda sign because of its thickness. So chorionic tissue intervening in between the 2 amniotic membranes. And amnionicity can be seen by seeing the number of amniotic cavities. And whenever you diagnose whether it is monochorionic, dichorionic, monoamniotic or diamniotic, it should always be documented because the complications are more in monochorionic variety.
You're right, Manisha Didi. And as we can see, we are very happy because I'll just use my laser pointer here. Yeah. We are very happy because about 70% of all our twins are dizygotic. So these dizygotic twins are dichorionic are diamniotic, and out of them 50% can have different sex, that is male, female, and 350 means half of them will have the same sex. But all monozygotic twins are monochorionic, are of the same sex. But a few of them, about out of 300, 100 of them can be DCDA because they split, they cleave at a very early stage of the morula. So if the cleavage is on day 1 to 3 post-fertilization, even with a monozygotic conception, you will get a DCDA twin. But when the morula turns into a blastocyst and forms a blastophill cavity, and cleavage occurs on day 4 to 8 post-fertilization, you get a monochorionic diamniotic twin pregnancy, which is the commonest form of monochorionic pregnancy. Third is momo twin, which is monochorionic monoamniotic, which is very scary because of all its complications. And the last, which is very rare, 1 in 1 lakh cases, is the conjoined twins. So coming to the this we have already explained that a dichorionic twin may not be only dizygotic, it would be monozygotic with a early splitting. And as rightly said by Dr. Manisha Khare, it is the chorionicity which is determined by the number of gestational sacs. This Dr. Divya already explained in a slide, so we will skip this. So can any of the panelists tell us, describe the chorionicity of these 2 images with the help of the intertwin membrane? Just give us a short explanation. Manisha Didi, you can also do.
Yeah, the first image is a dichorionic, diamniotic, because you can see the chorionic tissue, that is the intertwined membrane where it inserts into the placenta, that is thicker in the first case. Whereas in the second one, the membranes are very thin, that is T sign. So the second one is monochorionic, diamniotic monochorionic, second image.
So this first
This is the
image,
chorionic tissue.
yeah, here the chorionic tissue is peeking into the two layers of the amnion. So this is known as the twin peak sign or the lambda sign. It resembles the Greek letter lambda, and this is the T sign. And as rightly remarked by Dr. Divya, we should always determine the lambda sign and the T sign at the place where the intertwin membrane is inserting into the placental tissue. Dr. Pallavi, please, can you tell us how do we label the twins in multiple gestation? Dr. Pallavi is there? Dr. Pallavi, are you there? Okay, anybody can answer.
And
that?
Dr. Pallavi ma'am hasn't joined.
Yeah, I saw her in between. Acha, anyways. So I think Dr. Geeta has already. Who else is there in the panel? Dr. Vandana can answer this question. Dr. Vandana Agarwal Didi, you can answer. Yes.
Thank you, Monica, for inviting me as panelist. So the question is how to label multiple fetus, which was beautifully taught by Dr. Divya. The one sac and the fetus which is near to the cervix should be labeled as either 1 or 2 or A or B, which she has told, and which is away from the cervix should be labeled as the second fetus. And it is the observer which has to observe every time, like not like as we practitioner get the films, we cannot label as 1 or 2. Only the person who is doing the ultrasound has to label it as 1 or 2. Like in this picture which you are showing in A, the left fetus is in the lower, it's near to the cervix, should be labeled as fetus 1 or A, and towards the right should be labeled as fetus B or 2. And in so in the second film also, although the left fetus is up, but should be labeled as fetus 1 because it is near to the cervix. I think this is the concept which is taught to us.
Yes, this is very right. And nowadays, because we are more careful about the labeling, and in order to avoid any mistakes, we can also use additional markers for labeling, like according to the site at which the babies are placed, left or right, upper, lower, we map according to the placental edges, where the placenta is situated, anterior, posterior, fundal, lower, and the insertion of the cord. We can also label this is the right-sided baby whose placenta is in the fundus and the cord is attached to the lower edge of the placenta. And we can label the next baby. This is the left-sided baby where the placenta is on the posterior wall of the uterus and the cord is inserted into the middle of the placenta. So by the time the babies grow, we are liable to make lesser and lesser mistakes. Thank you, Vandana Didi. So next we come to our perinatal switch phenomena. So Dr. Sapna Jain, can you please tell us what perinatal switch is and why does it happen and why is it important to the obstetrician who's delivering the babies?
Thank you, Monica. I will congratulate you for this perfection series. I still remember my student days with you when you used to explain all these things so nicely. And you have, I think you have grown better and better in this now. And now coming to our question, perinatal switch is a new terminology given by ICER. And this is like when we label the twins, as you already said, and Dr. Vandana has explained, labeling of the twins. So twin 1 or twin A and twin B. So most of the time we expect that twin A is delivering first. But in certain, twin A means like the twin which is closer to the cervix, right? So we expect that this twin should be delivered first. but due to thin amniotic membranes, the twin B, which comes down first and delivers. So what is the clinical implication of it and why it is so important? Number one, it is for the emergency management of the fetus, which has congenital malformations which are not externally visible, like tetralogy of Fallot, congenital heart disease, or other structural abnormalities, which we like congenital diaphragmatic hernia or cardiac defects. So these babies require immediate management by neonatologists and immediate resuscitation also sometimes. So if we are aware that which baby is suffering from the congenital defects, we can hand over the neonatologist to the neonatologist. But what happens in type 1 baby A, which is not actually delivering, but it is B, which is delivering first. And by mistake, if we hand over the wrong baby to the neonatologist, it will be a mistake. And medico-legally also, it will be affecting the obstetricians. So I think that is the reason they have given this terminology, switch, perinatal switch.
Yes, it's very important, Dr. Sapna, you're very right, because see, in hospitals, we are, hearing the wrong side of the patient operated, the wrong eye operated, the wrong foot operated. And if the wrong baby is operated with the amount of birth rate we have in India, you can imagine what sort of grave mistake it will be for the parents and for the doctors. So I found this term very interesting. So handing over the next question to my co-moderator, Dr. Manupriya.
So a very good evening to all my esteemed panelists and listeners. And thank you, Monica ma'am. So the next question is how to screen for preterm birth in twin pregnancy. This is for Dr. Sonal Chand ma'am. Ma'am, can you please tell us?
Thank you, ma'am. How to screen. Ma'am, as we all know that twin pregnancies are at an increased risk for preterm birth. And as we do in singleton pregnancy, we look for cervical length by transvaginal scan between 16 to 24 weeks. And we usually take 25 millimeter as the cutoff. If the cervical length is less than 25 millimeter, the patient is considered to be at high risk for preterm birth.
Okay, so yes, ma'am, it's a very good answer. And, basically, we do a transvaginal scan and we try to give 2 to 3 minutes at least for measuring the cervix. The shortest distance, the shortest measurement has to be taken as the cervical length. Moreover, we have to avoid undue pressure so that the cervical length doesn't increase or is not enlarged or is not shortened. Moreover, there is one important thing that we have a FMF calculator where we can screen for preterm birth. So we can calculate the risk whether this patient, whether this lady is at high risk of preterm or not. And after that, if there's a history of preterm birth, so we have to screen her for 2 weekly, right? So that if she is at risk, then we may go for cerclage. Moreover, RCOG suggests that there's no any indication of history or ultrasound indicated cerclage, and if there is a history as well as and the ultrasound features suggest, then we have to put the cerclage. So we have to measure the transvaginal length of cervix from 16 to 24.
Excuse me, Dr. Manupriya, I think you should ask the panelists rather than let them speak. So you can just ask the questions and let the panelists give their own answers.
Next slides.
Yeah.
So this is the classification of preterm birth as we will use in our future cases. So extreme preterm, very preterm, moderate preterm, and late preterm.
So can any of the panelists please describe these severities of preterm births? And how is it important in clinical practice? Any of you can take the question. Dr. Vandana, Dr. Sonal, Dr. Virul. Virul has not answered, I think. Is Virul there?
Dr. Virul, ma'am was there.
Dr. Amarjeet, you can take this question. In clinical practice, what is the severity of preterms you see?
Survival rate will be obviously the perinatal mortality will be more as the gestation is early, and as the preterm is later on, the chances of perinatal mortality and morbidity will be reduced in this cases.
So when you get a preterm of around 34-35 weeks, do you refer it to the NICU, or do you prefer to keep it with the mother in your hospital and just tell your nursing staff to take care?
No, ma'am, we prefer to see that the baby is referred to a special neonatal care.
Dr. Manisha Khare, your husband is pediatrician. So
Yeah.
if you deliver a baby who is 34 weeks, what is your management like? Because I would like all youngsters to know at 34 weeks what precautions, and that patient has not taken steroid cover.
Steroids not taken.
Not taken.
Also
She has
there are
just come
chances
to you. She has come to you from Nilbur, and she is in full dilatation, and she's delivered the baby at 34 weeks.
34 weeks, so there are complications early preterm. It is a late preterm, but there are chances of respiratory distress syndrome. So you see for the distress, neonatal distress, then there are chances of hypoglycemia. All the complications of preterm delivery are there. So hypoglycemia, hypocalcemia, hyperglycemia can also be there. All the complications can be there, even sepsis, hemorrhage. So that is taken care of by a pediatrician. We usually keep them under observation in NICU.
Okay, thank you. Thank you, Divya. And definitely like about below 34, below 33 weeks, you give a very negative prognosis to the patient and you try to refer, but it is the 35, 36 weeker babies where the baby is, fairly good size. And the patient says, "Hum to ghar leke ja rahe hain." So that is the time we have to tell them that all these complications might develop as the baby is growing. What is your, Manupriya, you can now please take over again. I just intervened because you have to give more chance to the panelists to speak,
Yes.
please.
No, I was just talking about the FMF risk assessment. Yes, ma'am.
Ask everything from the panelists. We don't have to speak. Ask everything.
Now we have a choice of prophylactic vaginal progesterone, or we have a choice of prophylactic cervical cerclage. So what should we choose? And what are the indications of choosing it? Ma'am, can you please tell us who will answer it?
Anybody can take the question where the name is not written. It is open to all. What is your choice between vaginal progesterone and cervical cerclage surgical method? And what are the indications? What are the contraindications? And what does evidence and what does literature say?
They say that progesterone should be the first choice. It should be started early if there is a risk of preterm labor, and cervical cerclage should only be done if there is a history of previous preterm rupture of membrane, so previous history of preterm delivery.
Yes,
then we should.
Or it is a surgically distorted cervix.
Yeah, cervical trauma.
Cervical trauma is there. Dr. Sonal, what is your take on cervical cerclage?
Yes, ma'am. The use of vaginal progesterone has been shown to prevent or delay the preterm birth in twin pregnancies. And we do not prefer cerclage. Cerclage is done only when there is a history of previous birth and short cervix in this pregnancy.
Okay.
But Monica, can I intervene and ask you? Monica, can I intervene? I just wanted to add a comment that in patients with twins, progressively the cervical length can decrease. So in twins, you have to have it with a pinch of salt because cervical cerclage will help these patients. So I think offering cervical cerclage, because as the pregnancy progresses, the cervical length might may decrease even more as the pregnancy progresses. So you can err on applying a stitch than not applying. This is what I follow.
Actually, I also go very conservatively, Dr. Anshu, but the thing is, if you talk openly about cerclage nowadays in 2023, you are open to many controversies. So whoever is doing cerclage has to do it silently because literature and evidence has become, but Anshu is a very, very senior practitioner, years and years of experience. So Dr. Anshu, can you tell us, you have got DCDA twins. The cervical length at 16 weeks is 2.4 centimeter. There is no funneling at all. The patient is asymptomatic, totally comfortable. What will you do at 2.4 centimeter?
I know what you're hinting at, that we will just follow up and give a vaginal progestogen, explain to the patient. And we have to be very strict in our follow-up to see for the cervical length as the pregnancy progresses. Till 20 weeks, till 18, 20 weeks, we can still apply the cerclage. So if you feel that the length is becoming less as she's progressing, I would err on the side of applying a stitch than not doing it, because prematurity is a real big problem in twins. We all know that. And that is one thing we have to avoid at all cost.
You know what, Dr. Anshu, what I have seen, the tragedy, I saw a patient with cervical length 2.4 centimeter on 15th of a month.
Yeah.
On 18th of the same month, she came with total bulging sac.
That is what we are afraid of. We're so afraid of that.
2.4 centimeter to full dilatation in, just in 3 days.
That is what I fear. That is what I fear.
It is so scary that what will progesterone do? So
the review of literature will not work for a patient on a more podium like this. Yes, it makes sense. But to a patient to explain, I had come to you 2 weeks pehle, you did not even offer it to me. How do you explain to such a patient? I mean, it's a big nightmare for us as an obstetrician.
Yes, ma'am, I also agree with that, especially with the treatment like IVF treatment or IUI conceived, so much precious pregnancies. We can't take that risk. Yes, theoretically, for recommendation purposes, 2.4 centimeter length is not an indication, but I think we should be very practical in these cases.
Yeah.
Thank you, Dr. Anshu, for your inputs. That's really helpful, because that is a message to all youngsters that you are reading all literature, you are reading all the latest books, attending conferences, but doing cerclage is something like it is the evidence-based medicine it is the last part of evidence where only individual data counts. And Monica Singh's data, Anshu Jindar's data is nothing in world literature, but it is important for us. So sometimes you have to take that with a pinch of salt. Thank you, Dr. Anshu.
Thank you, ma'am.
Coming to case number 1, Manu, you can take this case.
A 34-year-old lady, she is gravid to para-1 abortion 1, no live issues. The first pregnancy was a spontaneous abortion at 6 weeks. And it is a present pregnancy. It is an IVF conception. The first ultrasound shows that there is a twin pregnancy. So, ma'am, Dr. Vandana Agarwal, ma'am, this is can you please comment on this image?
It is a diamniotic dichorionic, which is so beautifully explained recently by Divya, Manisha Didi, Monica, and the speakers. We can see clear-cut lambda sign or the intervening membrane inserting into the placenta, and the placental tissue can also be seen intervening in between the two membranes. So nothing left to be explained. Simple diagnosis, diamniotic dichorionic.
Thank you, ma'am. So the next question, what is the ideal follow-up schedule? So Dr. Virul Srivastava, ma'am, can you please tell us the ideal follow-up schedule?
Virul ma'am is not there, Dr. Monica.
Okay, Vandana ma'am, you can continue.
So in dichorionic diamniotic, it is the most simplest and very safest, as we are discussing since 2 hours. So first and foremost is to identify twins, then their cardiac activity and the cervical length. And then we have to go for, in the first scan, we have to see for the gestation sites, like in previous case, the diagram which was shown, it is diamniotic and 2 feti. And then we have to do the dating, as we have discussed, dating by measuring the CRL in first trimester, as it is in 9 weeks gestation. So CRL helps in dating the scan. Then labeling has to be done by the fetus which is near to the cervix or left or near to the fundus, as told and explained beautifully by Monica. And chorionicity, as we have already learned, it is dichorionic. And then After at 13 to 14 weeks, we have to look for the NT&B scan, which has to be done very intelligently, and there should be very good observation, the position of the fetus, because this is very important as we are having twins, and many of the twins are now IVF conceived. So we have to look for trisomy, rule out trisomy. Then at 20 to 22 weeks, we have to go for the target scan, the detail, that is the anatomy, biometry. And then we have to look for, again, the cardiac activity, because there can be, since it is diamniotic, dichorionic, very less chances of fetal demise. But still, if we have in any percent, we have to look for the amniotic fluid, the size of the live fetus, and very important in twins, the cervical length. Can I interrupt, Monica? Just one question I have to ask. Like, if I do not forget from you only, like as you have told, progesterone insertion is safer as the cervical encerclage. If any case, because we cannot miss, IVF conceptions are very important, what precautions are to be taken after cervical encerclage? Kindly highlighting us after this talk, because I had a very bad experience in my hospital with one of my patients, as I had also previously discussed. So again, to the topic, in the third trimester, we have to go for the fetal growth scanning. Regular checkups are required in diamniotic, dichorionic, like after every monthly, and in after 32 weeks, every 15 days, to look for the fetal growth scanning, amniotic fluid, and Dopplers, to see whether the fetus are growing well or not. And then we have to decide the time of delivery and the mode of delivery. So this is the antenatal survey, the fetal surveillance we have to look for. And simultaneous, we have to look for the maternal surveillance also, like because in twins, there are high chances of GDM, anemia, and PIH. So simultaneous maternal surveillance should also be done.
Okay, thank you.
Thank you, ma'am, for the beautiful answer and beautiful explanation. So now we did an NT scan. It was normal. No discordancy was found between the CRL. NT was normal. The 20-week scan, target scan was normal. Again, we saw further discordancy. There was no discordancy. Like it was normal in both the twins. Cervical length was normal and uterine artery Doppler normal. So we called her at 26 weeks. So at 26 weeks, the estimated fetal weight of both the twins normal, Doppler were normal. So we were reassured. We called her at again 30 weeks. So we saw that the estimated fetal weight of twin 2 was less than 10 centile. Doppler was normal. But there was discordancy was found between the weights of both the twins, and it was 20%. So what could be the diagnosis? Ma'am, Dr. Amarjeet, ma'am, this is a question for you, ma'am.
Well, as the pregnancy was progressing, absolutely, the twin pregnancy was progressing absolutely normally till 30 weeks. And after 30 weeks, what we see is that the twin 2 is having effective fetal weight less than 10th percentile. So that is a red flag for us that now we are more concerned, because the discrepancy is up to 20%. And for labeling as at a selective growth restriction, fetal growth restriction, according to latest criteria, it is up to 25% discordancy should be there. So when it is up to only less than 10% and it is up to 20% discordancy, I think this needs to be a red flag for all of us, that now this has to be, this pregnancy can have adverse fetal outcome. And so it needs to be followed up more nicely every 2 weeks. And it should also have a nice detailed antenatal scan and anomaly scan. I mean to say detailed anomaly scan if there is any other cause that is leading to a less effective fetal weight of this fetus.
No, anomaly scan has already been done, Dr.
Sorry. Yes.
So, but some papers are saying, Manupriya will, of course, she is the fetal medicine specialist, but some papers have said that discordancy of 20% is also enough in order to.
Yes, ma'am. Yes, in some it is 20%, but in recent guidelines they have shifted it to 25%. But what we studied is up to 20%. we go for selective fetal growth retardation in that fetus.
Dr. Amarjeet, please tell us how will you calculate the discordancy of the fetuses? What formula you will use?
Ma'am, in that the larger fetus weight is considered and the lesser fetal weight is we reduce that from that. And
formula batao? Formula batao, bhai, maths ka question hai.
Formula yaad nahi.
Anybody can tell us the formula?
Yeah, should I, Monica?
Yes,
Weight
yes,
of the
effective fetal weight of the larger twin
minus
effective fetal weight of the smaller twin divided by
effective
100.
fetal weight of the larger twin
divided by effective weight of the larger and into 100.
Into 100.
Very good, very good. Special chocolate for Manisha Didi and Vandana Didi. Okay. Next question, Manu. Yeah.
Yes, ma'am. So we re-evaluated her after 2 weeks and we found that twin 1 was normal, but there was a discordancy which has increased, and estimated fetal weight was less than 3rd centile for the fetus 2. Umbilical artery Doppler for fetus 1 was normal, but umbilical artery Doppler of fetus 2 shows raised pulsatility index, and it was the CPR ratio, which was 1.01, and short-term variation in CTG, dual channel CTG, was 4 milliseconds for fetus 2. So, Dr. Geeta Rai, ma'am, what could be the diagnosis, please?
So we already have discussed that probably it's a case of selective fetal growth restriction. And I would just like to bring to the notice that we have taken a case of dichorionic diamniotic pregnancy at the outset. So for that, I think it is definitely a thing to worry about, but not like as a case of monochorionic pregnancies, because DCDA twins are different pregnancies running at the same time. So of course, it's a case to worry, but because the Doppler changes have just started, so we are not in a hurry of really like thinking of termination of pregnancy and everything. I think we can just wait, and we know we are heading towards the fetal growth restriction, but we have to weigh the balance between terminating the pregnancy and landing up into the prematurity of a good appropriate for gestational age baby, or like continuing the pregnancy and losing a FGR baby. So we have to really balance those things and decide. For now, I think a strict fetal surveillance and follow-up in probably in a week or two so will guide us to treat further.
Yes, ma'am. Thank you. Thank you for the beautiful explanation, ma'am. So we are following the Delphi consensus and ASIO guideline, which suggests recommended that there are some criteria for dichorionic as well as monochorionic to label them as growth restriction. So if the fetuses are on very low centiles, like 3rd centile, then a single criteria can be used. But for dichorionic, if 2 out of 3 criteria are present, then we can label them as fetal growth restriction. And in monochorionic, if 2 out of these 4 criteria are present, then we can label them as fetal growth restriction. So, ma'am, next slide, please. Yes, so the next step we did, we called her weekly after 1 week, and we did the biometry and fetal Doppler. So fetal Doppler was CPR ratio was 0.9, and short-term variation in CTG was less than 3 milliseconds. The discordancy remains more than 25%, and the estimated fetal weight was less than 1 centile. So what could be the next intervention we can do? Dr. Manisha Khare, ma'am, please.
Now the only option left is delivery under the cover of steroids, and all the precautions to be taken for preterm delivery. We have to give steroids, we have to give Maxel for neuroprotection, then we have to counsel the couple. They should be agreeing first of all. And the approach has to be multidisciplinary. We have to involve the fetal medicine expert or an obstetrician or neonatologist, anesthetist, and radiologist.
Yes,
and we have to deliver.
Yes, ma'am. Thank you, ma'am. Thank you. Thanks a lot. So there are certain guidelines. Now there is a recent change in guideline for steroid cover. I think Dr. Purnima will highlight some recent changes.
Yeah, Purnima, please tell us about the steroid cover, role of steroid cover, and role of Maxhelp neuroprotection, current guidelines.
I think, ma'am, she's not here. She's
Okay. Then you can continue, Manu, you can continue.
Yes, ma'am. So the recent RCOG guidelines suggest that we can give this steroid up till 33 plus 6 weeks. After that, we have to balance, we have to weigh the pros and cons, because it is seen that there is an increased risk of autistic spectrum and neurodevelopment problems in the fetuses. Although you all are very, I'm an experienced obstetrician, so we have to see our patients and we have to weigh the risk as well as the benefits the steroid can provide. So we have to balance it. So it is suggested that offer and consider. For Maxilf, we have to offer them till 30 weeks, 29 plus 6 weeks. But if fetus is more than 30 weeks, then we have to consider weighing the pros and cons for giving the magnesium sulfate. Okay,
Didi, Manisha Didi and Vandana
Yes,
Didi,
yes.
you
Yeah.
have lots of experience. So please tell us about Maxilf, your regime. How do you use it and what is your experience?
So it has to be used in the same manner as in eclampsia. You have to give 1 gram of magnesium sulfate IV, 4 grams IV, and then 1 gram per hour is to be given by infusion pump. 1 gram per hour, and delivery is to be conducted within 24 hours. So in this case, I think we'll do Caesar, and before cesarean we can give this, and next day we have to deliver the patient.
So a baby of 33 weeks and the patient with 33 weeks mean gestational age, still Maxilf is required, Manisha Didi?
For neuroprotection, they say
at 33,
it has to be given 30 to 33 weeks of pregnancy. No, it is 33 weeks. No, so in twins, otherwise also in selective FGR, we deliver at 34 weeks because there are chances of sudden IUFD. Once the baby dies, we cannot do anything. So you have to deliver and you have to give both the things.
So my question is, at 33 weeks, still Maxilf is required?
What is your opinion?
I don't know. That's why I'm asking you.
We give Maxilf. We have given in preterm deliveries.
Vandana Didi?
33, I give neuroprotection by Maxilf along with steroid coverage, because in this era of very literacy, patients, they do Google reading and it is effective also. We have to consider giving neuroprotection as obstetrician also for the safety of the baby. And we can continue by fetal surveillance till we achieve, like we reach 35, because after neuroprotection, it is not necessary or mandatory to deliver. And after giving the steroid, we can wait, we can go for Dopplers, we can do very strict fetal surveillance and deliver whensoever required, because this will reduce the NICU stay and reduce the morbidity and mortality. I give neuroprotection.
But I
in less than 34 weeks. In 34 weeks, less than 34 weeks.
But with Maxilf, you have to deliver within 24 hours.
No, it is
So
not.
we will deliver within 24
If we are
hours.
giving it
We'll
for
deliver after.
protection, that is lower dose than what we give for the pre-eclampsia.
Because it is not in the full dose. No? Neuroprotection is in the lower dose, so you can extend with surveillance.
Okay.
It's not mandatory to deliver just after giving the Maxilf. Even in PIH patient, we can give the full dose of Maxilf, like 14 gram loading dose, and to be followed after, like we have taught Pritchard regime, that is intramuscular, but you can give with Zuspi like IV, because we are having infusion pumps, and we can look for albuminuria and we can extend the pregnancy. There is no harm. It will act as neuroprotection.
What is the harm in giving Maxilf? Why do you
There is
ask?
no harm in giving Maxilf. There is no respiratory depression in the fetus.
Maxilf itself can cause, ma'am, respiratory depression, and it always needs.
But it never happens in practically. We have not seen.
If we are using eclampsia with calcium channel blocker, it can lead to respiratory depression, knee jerk, and ICU admission is mandatory in Maxilf admission.
It is very rare. We have given so much of Maxilf in eclampsia patients.
And for it is very clear from the guidelines that if we are giving Maxilf for imminent eclampsia for eclampsia, then we have to deliver. For baby in which delivery is expected, then usually most of the guidelines says 32 weeks, but it is on obstetrician perspective. They can give up to the 34 weeks, but minimum it should be given between 8 to 24 hours minimum. Then it will be effective. After 24 hours, if labor patient is not, we can.
So you have to deliver her also within 24 hours after steroid coverage.
And the neonatologists are very happy that yes, every step has been taken.
Every neonatologist want to Maxel to be given. They usually ask.
Right. So these are some confusions in my mind also. That is why I asked, because we are having such experienced obstetricians in the panel. So we wanted everybody to benefit. Thank you so much. So Manu, you'll continue.
As already discussed, these are the potential causes for IUGR, like genetic factor, placental factor, fetal and maternal factors that we have to look for the managing our patients. And especially if there's a difference in NT, or difference in CRL in the first trimester, then we have to be very vigilant, because early fetal growth restriction can set in, and then we have to look for definite causes, especially in anomaly scan and any other genetic causes which can be there in fetuses.
So if you find a discordance in the NT or CRL discordance more than or equal to 10%, NT discordance more than or equal to 20%, it should be discussed with your fetal medicine expert, because this pregnancy might give us trouble as it advances. So these are the complications of selective FGR you were discussing, Dr. Manika?
Has already been discussed, yes. So perinatal, yes, we have already discussed the complications, like, and lesson learned and take-home message is that iatrogenic prematurity we can avoid even in twin and multiple order pregnancies by evidence-based algorithm and clinical surveillance, close clinical monitoring. So this is our first case, and here is our second case, ma'am.
Okay, so second case, Pallavi is there? Pallavi is not there, no?
Yes, ma'am. Yes, ma'am, I am here.
Pallavi is here. So Pallavi, she is a 35-year-old woman, primigravida, carrying a 10 weeks gestation. And this is her first sonography. As soon as you put a probe, I think Pallavi, you do your scans yourself, no?
Not ma'am, 12 weeks. I am not expert as you. Up to 9 weeks.
Abhi 10 weeks ही हुआ है, अभी 12 weeks हुआ नहीं है. So she has come to Nova, and you suddenly put a probe and you find this. So describe this pregnancy, Pallavi.
So ma'am, it is very clear that it is twin gestation, and it is clear that it is diamniotic, because two sacs are seeing and inter-twin membrane is already visible here. But the important thing is there is the inter-twin membrane that is forming a lambda sign, but actually it is T sign. Actually it is T. We are not seeing any chorionic tissue in between that amniotic sac. So most probably it is monochorionic diamniotic pregnancy that can be monozygotic or dizygotic. That depends upon the number of embryo transfer, or even in the early pregnancy, 8 to 9 weeks, usually 6 to 8 weeks scan defines the zygosity, and 10 to 12 weeks scan is very useful for the chorionicity.
You know why you are getting this typical shape over here?
Lambda sign.
Yes, a T sign actually. It's not a lambda sign. This is a T sign.
It is a T sign. That is seen in
monochorionic. The amnion and the chorion have not fused.
Monochorionic.
Yeah, no, it has not fused. That is right. It is actually a T sign only. It is not a lambda sign.
It is T sign.
So this is a monochorionic diamniotic pregnancy. Now, please tell me, Pallavi, what should be the antenatal care protocol of a MCDA twin or any MCMA twin?
So whenever we consider, ma'am, a twin pregnancy, so least there is no least in twins, but DCDA has better prognosis than MCDA, and MCDA has better prognosis than MCMA. So in MCDA, there is high risk of TTTS, TRAP, and TRAP. All the risks are there in.
No. Pallavi, let us stick to the antenatal care.
Every 2 weeks, I have to call the patient, and every 4 to 6 weeks, I have to plan her sonography, especially sonography with Doppler. So first scan, if I am doing 6 to 8 weeks, then 11 to 14 weeks, 16 weeks for cervical length and fetal growth, 18 weeks anomaly scan, as we all do, 20 weeks scan, then 24, 28, 30. Meanwhile, we have to schedule visit every 4 weeks.
So have you realized something? That here after 16 weeks in monochorionic twins, you have to monitor 2 weekly. That is the main difference with dichorionic. Dichorionic, we have repeatedly said you can be as comfortable as singletons. So singletons you are seeing maybe 6 weekly or 4 weekly, but dichorionic you can see 4 weekly. But in monochorionic, your red flag comes at 16. And after 16, you don't leave the patient. In monochorionic, irrespective of the amnionicity, you will monitor at 18 weeks, 20 weeks, 22, 24, 26, 28, 30, 32, 34, and probably after 34, you will terminate because very few MCDA twins will progress to 36. See, we are not going beyond 36 because we are expecting some complications will arise. And how will you manage these complications? What are the special Doppler parameters you use at 16 to 20 weeks in order to monitor monochorionic twins? Anybody can take this question because this is slightly complicated. Manisha, yeah, Sonal, please take
Ma'am,
it.
apart from fetal biometry, effective fetal weight of both the twins and deepest vertical pocket of amniotic fluid, we will also look for MCA, middle cerebral artery PSV of both the twins to look for any complications like twin anemia,
Polycythemia sequence.
Polycythemia or signs of TTTS monochorionic pregnancy.
Why are you measuring the DVP in both the sex? What do you want to detect early?
Rule out if there is an oligo poly sequence, if there are signs of twin transfusion syndrome.
Yes. So DVP is measured in both the sacs because you want to rule out TTTS. Uterine artery PI, mean uterine artery PI is done in order to detect early PIH. And MCA PSV is done in order to detect early onset of twin anemia polycythemia sequence. Cervical length is measured.
It is umbilical artery PI.
No,
umbilical artery PI. It is not uterine.
Umbilical.
It is umbilical artery PI is to be measured.
Yeah, and the uterine artery PI is also measured, Didi, for PIH.
Yeah, that is in from first
Mean uterine artery PI. Mean uterine artery PI.
So at 28 to 30 weeks in this patient, you will again go for fetal growth, DVP, and continue the same monitoring and try to prolong the pregnancy as far as possible. So your pregnancy is going safely, but you are now worried about aneuploidy screening. This patient is 35 plus and she has got monochorionic twins. So Manisha Didi, how will you screen for aneuploidy in the first trimester?
In the first trimester, it is a monochorionic pregnancy.
Yes,
so yeah, you have to screen by combined method, NT, maternal age, then NT, then PAPA and beta HCG, combined screening. But if there is a vanishing twin, then these are not effective. Then you have to only see on the basis of maternal age and NT scan. And as already discussed previously, so NIPT may be an option because it has a high detective rate and low false positive rates.
Okay, so now I'll ask a very interesting question to every panelist. I'll take out a slide also for it. How do you detect the NT in DCDA twins and MCDA twins? What is your deduction? NT, MCDA में कितने NT होते हैं और DCDA में कितने NT होते हैं babies के? Anybody can take this question. If somebody had attended Chinmay ma'am's lecture 5 days back, it was with Bhopal Obs-Gynae Society. So this was a very beautiful lecture. Anybody can take a question. Now there is a set of DCDA twins, patient Sita, and there is a patient Geeta who has got MCDA twins. दोनों पेशेंट का एंटी स्कैन हमने किया है. सीता के कितने एंटी होंगे और गीता के कितने एंटी होंगे?
Ma'am, monochorionic will have an average NT. It will be pregnancy specific, and dichorionic will have fetus specific NTs.
Two NTs. So that is right. In monochorionic, the message I want to give is that whenever you see you send biochemistry combined fetal first trimester screening in twin pregnancy to your lab and to your fetal medicine specialist. Please specify to your lab whether it is monochorionic or dichorionic. And NT given in monochorionic twins is an average of the two NTs. See, in this picture, it is clearly that one twin A is having an NT of 1.8 mm. And twin B is having an NT of 4.2 mm. So this is slightly higher NT, but still you're not worried, but the combined NT you give is 3 in such case. So any discordancy of NT in monochorionic twins will be diluted by the effect of the average, but this will not happen in dichorionic twins. Now, another thing I wanted to tell you was the value of NIPT. Anybody can comment on NIPT in DCDA twins first trimester and NIPT in MCDA twins first trimester? Dr. Sonal, you can take this question. How does NIPT work for twins? Is it totally useless? You should not waste the money, or it has got some significance?
Ma'am, if NIPT is normal for if it is normal in dichorionic twins, no testing is required. And if it is raised, then we have to test both the twins for invasive procedure.
So what I wanted to, I have been reading this topic since 5 days. So, so I can just tell you the recent guidelines that NIPT is a very fantastic test in first trimester for all twins. And maybe not now, but 2 or 3 years down the line, NIPT will be as important as singletons for twins. NIPT has got a very high detection rate of 99% for DCDA twins, same as singletons, or even more than singletons. And in MCDA, it is even higher because it is a single sac. So if you find NIPT, both normal, means in DCDA twins, NIPT is normal, there is no testing required. But if NIPT shows a high risk, then you test both the fetuses and we expect an invasive test. We have to advise an invasive test. So NIPT is not a strict no, but definitely no second trimester biochemistry in twins, no quadruple marker. So if a patient comes with quadruple marker in the second trimester, you have to not consider that report. And the traditionally for screening for aneuploidies in twins has been the pregnancy specific maternal serum biochemistry. That is the measurement of beta HCG and pregnancy associated plasma protein and the very well done USG. Your USG is your the stand alone sort of test, which has to be used in order to allocate the risk to each fetus for aneuploidy. Scan assessment is the best assessment. About vanishing twin, we have already talked. So the second problem with the MCDA twins is the aneuploidy. And what other specific risks are associated with MCDA twin pregnancy? Dr. Vandana, can you tell us? What are the other risks associated with monochorionic pregnancies about which you are worried? Manisha Didi, you can take this question.
See, all the risks are because of the anastomosis between the circulation abnormalities. So there can be twin to twin transfusion, there can be selective FGR, there can be reverse and twin anemia polycythemia sequence TAPS, or there can be twin reverse arterial perfusion sequence, or there can even be single intrauterine death. All is because of the circulatory problems. The diagram which Divya gave,
that is the vascular anastomosis in the
vascular anastomosis. One, they are eating from the same kitchen. One eats a lot, the other one doesn't get any supply. So that is the problem. One grows, the other doesn't grow. Yeah.
So the most important carry home message of this panel is that in a DCDA twin, if you have a single fetal demise, you are not worried. Unless there is some other problem like bleeding, hemorrhage, or onset of preterm labor. You're not worried about the surviving co-twin. But in MCDA twin, if there's a single intrauterine death, it is a big risk to the other twin. So if you have selective FGR in monochorionic twins, again, you have to really importantly rely on the Doppler of the umbilical artery. If the Doppler is showing good end diastolic flow, normally these fetus have good prognosis. But if there is absent or reversed end diastolic flow or intermittent or cyclical end diastolic flow, then it's a poor prognosis, and there is high risk of IUFD and neurological damage for both the twins. So according to the severity of the condition, the parents' counseling and the technical facilities available in our city, we can go for expectant management, cord occlusion, or laser ablation.
Nobody is doing cord occlusion in our city, no?
I think Bansal Hospital, Mudita was there. We are doing some laser ablation. And what about Apollo?
Yes, ma'am. We will start recently in few days or few months.
I think.
So kahan par?
Apollo.
Apollo Sage.
Apollo Sage for that. Okay.
Manupriya is in Apollo Sage, so probably
she must be knowing.
Yeah.
Yes.
We will have a good unit. They are starting IVF also, and they will have this fetal fetal intervention also. So this is all about dichorionic and monochorionic. See, dichorionic, we are comfortable with the term delivery. Even with one FGR fetus with abnormal Doppler, you can go to term delivery, and you plan a preterm delivery as per the better twin. But here in monochorionic, it is a very tricky condition, and preterm delivery with query cord occlusion or preterm delivery as per the worst twin, because here if the worst twin is getting worse, you have to plan a delivery not according to the.
Then it may hamper.
Yes. So Manupriya, you can talk about single fetal demise. Yeah.
Yes. So next slide, ma'am. So now we have already discussed about the single fetal demise. So, what are the specific risks to the surviving co-twin if one fetal demise is there in MCDA twin pregnancy? So this is for Vandana ma'am. Ma'am, can you please tell us?
The main etiology we have seen so beautifully described by Dr. Divya, that there is intertwining of the vessels in MCDA twins. So if death of one co-twin occurs, which occurs in 15% of the cases as described, so what happens? The blood circulation from the surviving fetus will go to the dead fetus. So there will be hypoxia, there will be less perfusion, and hence there will be neurological deficit to the surviving fetus. So after delivery also, we have to do the postcranial imaging, and we have to look for the neurological deficit in the surviving fetus. So this is very bad. And so we have to look for it. And I think the fetal medicine person who are working in Bansal and soon Manu in the SAGE, if you will do the laser therapy, you can stop the perfusion or the circulation from the surviving to the demised fetus, and hence prevent the complication in the surviving fetus. Then preterm delivery can.
Well, that is the very sad part, Vandana Didi. Even if we do laser ablation and radio frequency ablation, still the neurological damage cannot be prevented.
Have already been occurred at the time.
Yeah, that occurs immediately. So by the time you diagnose fetal demise and start doing cord occlusion, the neurological damage has already set in 80% of the fetuses, and out of that, half is major neurological damage. So it is a very sad situation, especially in developing countries. In developed countries, of course, even these neurologically handicapped babies are, taken care of by the system. Okay, we can continue, Manu.
Yes, ma'am. So what could be the further management if there's one demise in MCDA twin? So how we will monitor and do the surveillance, ma'am? Can you?
Yes, I think they have already talked,
Yes, so it is the fetal MRI and MCDA.
Suppose there is no damage. Once you do uterine artery PI and it is normal, that means there is no damage which has occurred. Then you have to monitor it every 2 weekly. And then you have to deliver at 34 to 36 weeks under steroid.
Then you can continue. Yes.
It's not necessary that the damage occurs.
So single fetal demise with DCDA. Who wants to describe this? Manisha Didi, you want to tell?
Yeah. See, in first trimester, if this happens early, there is no harm. slight vaginal bleeding and abdominal pain, and the other fetus dies and the other one continues. And if it is later on, then the prognosis, that is, it depends upon the gestational age.
Yeah, yeah.
If the loss occurs in first trimester, nothing happens. And then if the death occurs after 14 weeks, especially after 20 weeks, it is associated with a high risk of prematurity, preterm labor of the other fetuses.
But that might not happen. If you have got a good antenatal care, you can even carry on till term with a dead fetus.
Yeah.
Yes,
So you have to be more vigilant. You have to monitor it weekly, weekly or weekly.
Probably just masterly inactivity and surveillance. Okay. So we want to do the third case. Do panelists want to finish or we want to carry on?
Finish it early, no? Finish it
early. चलो जल्दी से करो मनु, इसको जल्दी से कर लो.
So this is an IVF conceived pregnancy. Ultrasound was done at 7 weeks. 2 blastocysts were transferred. So we can see there are 3 fetuses. Ma'am, can you tell me the diagnosis? Dr. Virul Srivastava, ma'am.
Virul is not there. Sonal bata degi.
Ma'am, it seems to be a dichorionic triamniotic pregnancy.
Yes. So this is a dichorionic because we have got a twin peak sign or lambda sign, and we could see clearly 3 amniotic sac. So we did a NT-NB scan at 12 weeks. It was normal. No, there was no discordancy between CRLs. NT was normal within limits. So what could be our next step?
And we can offer the selective fetal reduction to the patient, or if she does not want to undergo reduction, she can continue with expectant management, while we will explain the risk of extensive preterm delivery of the fetus and increased risk to the mother as well.
So this is exactly the same case that like Dr. Anshu Jindal was talking about. Her patient refused to undergo fetal reduction, and I think that is she has sent the link on YouTube of that case, which everybody can watch in the chat box. Okay. So next question.
So if we do a selective reduction, so what are the benefits of selective reduction in higher order multiple pregnancy? Dr. Amarjeet, ma'am?
Benefits are it will reduce the overall perinatal and complications, maternal and perinatal complications.
Yes, ma'am. So twin and single pregnancy is better than a triplet or higher order multiple pregnancies. So the next question is, what could be the risk to the mother and the fetus in higher order multiple pregnancies?
Okay. Everybody knows that what are the risks.
So when to do the selective reduction?
11 to 14 weeks, I think.
Yes, it is.
It is better to do it a little later rather than early. Better to do it because sometimes the anomalous fetus or one of the fetuses of monochorionic can have spontaneous demise, or both the fetuses can die, So wait for 8 to 9 weeks for nature to take this course. Sometimes MCDA twins and, these have one fetus which does not survive after 8 to 9 weeks. So you always plan your reduction after 10 to 11 weeks. What do you say, Manu?
Yes, ma'am. So we generally do a NT scan, look for any anomaly. If there is, we do a detailed scan, so we can make out whether the structures are normally developed or not. So after that, we take a decision whether to reduce the fetus, which fetus has to be reduced. So it is very good that we do it at 11 to 13 weeks or early second trimester if it is missed.
Yeah, and the one practical tip is that we have done many selective fetal reduction. We've also done for one VIP patient reduction of twins to singleton. She was a second pregnancy and she already had one baby and she did not want twins at any cost. So we had to reduce one of the DCDA twins. So, despite everything, so it's better to have the transabdominal approach, and transabdominal approach also try to take the twin, which is easiest to approach by the needle or under ultrasound guidance.
So if the patient has refused, then it is a triplet pregnancy. And then as already been discussed, the care, antenatal care and close surveillance of triplet pregnancy. So ma'am, who will take the follow-up care of triplet pregnancy?
Vandana Didi, how will you follow triplets?
यार हमने तो ट्रिपलेट्स देखे ही नहीं है अभी तक और तुमने दिखाई ही नहीं है
anybody out of the panelists has delivered
Triplet is always associated with risk of preterm delivery. We have to monitor very carefully, and especially in this case every 2 weekly, because there is monochorionic pregnancy. Most of the pregnancy in triplet doesn't go beyond the 34 weeks if we are lucky. Else
32 भी नहीं होता
32 भी नहीं होता मैम. One patient I have only one patient I have seen. Usually most of them delivered at 30 weeks around 30 weeks. 32 they have not reached. So main
हो जाता है labor start इनका.
And हो जाता है मैम. And one very important aspect of their delivery is neonatal NICU counseling. That has to be done very properly at the decision making time. At the 12-13 weeks, they should be aware of the cost of NICU in event of delivery at 28 weeks, 30 weeks, 32 weeks, because there is huge difference in the cost between 28 weeks, 30 weeks and 32 weeks in case of triplet, because the birth weight will be even lower than singleton or twin pregnancy.
Okay. Thank you, Dr. Pallavi.
I think the lung maturity comes earliest in the number of fetus increases. So in triplets, I think at 30 weeks हमको इतना डरना भी नहीं चाहिए क्योंकि मेरे ख्याल से lung maturity जल्दी आ जाती है उनकी. As compared to singleton. Singleton में lung maturity after 37 completed weeks. In twins, I think it comes early at in monochorionic और थोड़ा जल्दी dichorionic, which I had read in my books. और triplets में मेरे ख्याल से और जल्दी आ जाती है तो उनकी survive जो status होता है वो ज़्यादा होता है triplets का. Kindly मेरे को और highlight करें इस चीज़ पे. ऐसा?
I really don't know, Vandana Didi. I have not read this, and I'm a little doubtful about this statement, but I will get back to you after we confirm with the literature. I have not read about it. So, so methods of selective reduction, anybody can take. What are the methods used for DCDA twins, and what are what is the method used for dichorionic twins and for monochorionic twins? Methods of selective feticide.
Ma'am, for dichorionic twins, we go for intra-abdominal KCL injection, and that is done after taking
not intra-abdominal, intracardiac.
Yes, intracardiac KCL injection, 0.5 to 2 ml is taken till the asystole is achieved, and then we follow up with ultrasound whether the patient is stable or not.
Okay. And for monochorionic, naturally,
for monochorionic, we cannot do this. So we go for laser ablation or radiofrequency ablation.
Thank you. The last case was this Momo twin, monochorionic, monoamniotic. You want to just give 2 lines about this, Manupriya?
Yes, ma'am. So we can see here at 6 weeks of scan that there is one chorion. So this is a monochorionic, and there's only one amniotic sac. So this is a monoamniotic twin. So we are worried about in monochorionic, monoamniotic twin because they are the most dreadful twins. We initially it was thought that it is the umbilical cord entanglement which is responsible for death in the twins, but not exactly. It is the prior events like TAPS, which is responsible for demise of twin in Momo twins. So if the pregnancy continues, we see that there is a preterm birth in which occurs in less than 24 weeks. So if pregnancy continues, so we have to closely monitor the pregnancy Momo twins every 2 weekly after 16 weeks. And there are various school of thoughts ki like inpatient management kare ya outpatient management kare, but it doesn't matter. Inpatient management se bhi the surveillance only closely, we can closely monitor them, but we cannot predict the outcome. It is just sudden demise which can occur in Momo twins. And that's why we are just worried about it. So if there is discordancy in fetal size or any abnormal Doppler, so we have to monitor it weekly. And since it is very high risk of fetal death after 32 weeks, so we have to deliver by cesarean section at 32 weeks. And after that, the risk of increases.
It's very rare you reach 32 weeks with Momo twins. The complication rate is so high that not even half of the Momo twins will cross 24 weeks, I think, according to literature.
Yes, ma'am.
So finally coming to the end of our panel, we have to do USG assessment of multiple pregnancy. There are multiple uses of USG in multiple pregnancy. And that is my message to all the obstetricians sitting in this panel. Manisha Didi and I, we've already entered this field, but the rest, everybody of you, each one of you invest in a good machine and start doing dating, chorionicity, anomaly screening, routine monitoring, specific monitoring, USG guided procedures. Of course, you have to take special permission from PNDT, and you can, of course, screen for preterm birth if you are expert in your USGs.
And it takes a large time. It takes 45 minutes for each fetus. If you do anti-scan, it takes a lot of time.
So one advantage with Manisha Didi and with Monica is that we are total Vela people. So we can, so we study a lot and we do lots of ultrasound. Yes, Didi? So, so the take-home messages are that chorionicity is the most important finding in multiple gestation, which should be diagnosed and always documented. And Chinmay madam said very correctly in last webinar that you take a film of the chorionicity and paste it in the patient's file and also keep it in your records for future use. Because as the babies will grow, you will stop seeing the membrane and T sign and lambda sign after 14 weeks.
16 weeks.
Always label the yes, Diti. Always label multiple gestation fetuses appropriately. Use as many markers as possible in order to avoid making mistakes. Wherever it is a monochorionic, twin gestation, or any sort of triplet gestation, take opinion of fetal medicine expert who are there now in a city, because they have lots of complications and we don't want litigation. Single fetal demise should be tackled according to chorionicity. Aneuploidy screening in multiple gestation requires special guidelines. Again, here chorionicity is very important. Preterm labor is very common and we should carefully monitor cervical length, preferably by transvaginal sonography. And if by now you are sick of listening to chorionicity, our job is done, because the most important thing in multiple pregnancy is chorionicity, chorionicity, chorionicity. And first do no harm to yourself and then do no harm to your patients, because obstetricians will always have dilemma of multiple pregnancy, and because of multiple pregnancy, you cannot put your practice and your peace of mind at stake. Ultimately, we want these two DCDA twins who do not look like each other, but who are dancing their way to, nicely. Thank you for the brilliant involvement, dear panelists, and thanks, dear audience. Thank you.
Thank you, Monica.
Thank you. Thank you so much. And thank you for this late hour. Everybody was there and I'm so grateful for it. Perfection series thoda lamba chal jata hai, but I'm so thankful. We will have one group photo. Please, everybody put on the camera and smile. Okay. Acha, Varuna ji chali gayi. Okay. 1, 2, 3, cheese. Say cheese, everyone. Varuna.
Varuna hai. Vandana gayi hai. Vandana kahan hai?
Yes. Yes.
One photo.
Yes, smile everybody. Yes. Smile everybody. Yes.
Randhir kahan hai?
Yeah, no, ma'am. Yes, ma'am.
Hara camera off hai.
Camera mein nahi ho.
Camera. Yes, yes. Yes, ma'am. Yes.
Okay, I'll put the photo in box. Thank you. Good night, everyone.
Good night.
Thank you. Thank you, Monica. खूब twins पढ़ लिया, 3 दिन से पढ़ रहे हैं जन्माष्टमी के बीच में.
Thank you, ma'am.
चलो, bye.
Bye. Good.
Thank you.
Bye, Archana.
Thank you, Purnima. Thank you, Manipriya. Bye, Amarjeet. Amarjeet सबसे पहले आ गई थी. Thank you, Pallavi. Thank you, Dr. Vishal. Thank you, Inga.
पहली बार मिल रहे हैं अमरजीत से, और एक और कौन है? एक और थी ना, वो लड़की कहाँ की थी?
Webinar will be on YouTube, so we can always watch it whenever we want and revise the lectures. Thank you so much. Thank you for Perfection Series episode 7. Thank you.
Bye-bye.
Good night.